Thanks everybody for being here, and I mean everybody. We're going to find some chairs or an overflow room or something so everybody can participate. Today's meeting builds upon the state of biodefense, the briefing that the executive director of our commission, Dr. Asha George, delivered to us in May. Not much has changed since then. This remains a time of painful transition and uncertainty. The fact is that many good people have lost their jobs and seen unwarranted disruption to their lives for what seems to be maybe a questionable benefit to the country. Hand in hand with that upheaval is the growing concern that the long-standing capabilities to address biological threats are weakening or worse, disappearing entirely. While every administration has the right to review existing policies and programs, they should only make drastic changes after carefully considering and planning for what they need to accomplish their goals, and in this case, defend the nation from biological events. Understanding that much remains unclear about what the future holds for federal biodefense programs, our capabilities, and today we will talk about what is certain. What is certain is that there are immutable requirements for biodefense. We know that what we will need to develop an operating picture to track the movement of outbreaks, epidemics, and pandemics if we want to have any hope of stamping them out. We know that diagnostics and medical countermeasures are essential tools for responding to and lessening the death and suffering brought on by disease. And we know that we cannot ignore the global community. The global community that we live in when we discuss the origin, spread, and existential nature of the biological threat. And we know that while states, localities, tribes, and territories are the first line of defense during a biological event, they are not the only line. During our last public meeting, Dr. George expressed the sentiments of this body in the first annual State of Biodefense address, and she rightfully pointed out public health and the larger biodefense community have to make do with very little for quite a long time. Dedicated public servants have found ways to make meaningful changes in their towns, in their cities, in their states, and in the country, in many cases, despite a lack of resources. The biodefense community finds itself facing yet another challenge, but the mission remains the same. Next, I'd like to ask my commission co-chair, Governor Ridge, if he'd like to make any remarks. Tom?
Well, thank you, Donna. The first set of remarks I would like to say, as we used to say on the floor of the House of Representatives, as you well know, I would like to be associated with your introductory comments, particularly about what's happened to the medical infrastructure within our government. So thank you, Donna, and good morning, all. I'm very pleased to join my fellow commissioners gathered today to talk about a very basic question. It's my hope that we will be able to find, I'm quite confident we'll have a good discussion about the biodefense do list. Then we can go from there to further strengthen our capabilities to address that list. I'm glad and pleased to see that State Veterinarian from Pennsylvania is here today. My home state, like many others, has faced many different disease threats over the years, with bird flu being the most recent. We have learned a lot of lessons in the meantime, and I'm grateful that we have Dr. Alex Hamberg here to discuss some of those lessons and what the government needs to address them moving forward. So once a gov, always a gov. So pleased to have someone from Pennsylvania joining us today. The question that we deal with at every session is, how do we keep the nation safe from biological threats? It's a fairly straightforward question, and one this body has taken up in multiple different ways over the years. But regardless of our efforts, the biological threat remains the same. Regardless of our policy or funding discussions, made by administration or Congress, past or present. It is an ongoing threat. I am certainly pleased we'll be revisiting this topic, the topic of leadership at the meeting. Any elected leader, mayor, governor, or president knows that to tackle a problem, first you doggone well better understand it, its complexity, and its consequences. I certainly look forward to hearing from our panelists and having a very good discussion today. And I want to thank all in attendance and participating for their efforts and joining us on this important effort we've undertaken today. And back to you, Donna, and I want to thank you again with your absentee co-chairman. You've had to assume most of the burden of leading this organization, and I look forward when I'm back in a position to be a more helpful partner in this effort. So pleased to be associated with you and my colleagues on the commission. Thank you.
Thank you very much, Governor. Knowing that you're the co-chair makes all the difference in the world. We'll start with our first panel, and we rotate the chairmanship of each of the panels, and Ken Weinstein will introduce panel one.
Okay, thank you, Donna. Good morning, everybody. The first panel is a very important panel, and as previewed by Governor Ridge, leadership in the biodefense area is a major concern generally, and it's a concern of ours. And I need leadership in turning on my gizmo here. Does that work? There we go. Leadership. That's what we're focused on here in the first panel is what leadership is needed in the biodefense area. It's an issue that we've wrestled with since the very beginning of the commission. I think we've seen historically a lack of prioritization on the biodefense issue by administrations and Congress over the years, and a decentralized management of the issue across the federal government. That's a major challenge. It's one that still bedevils the biodefense mission today. To discuss that topic and the imperative of improving that situation, we have two experts with us today that I'm honored to introduce. First is Dr. Michael Place. He's Major General Michael Place, is the former Chief of Staff of the Office of the Surgeon General. He has served for 37 years in a variety of positions, from family physician to working in distinguished units such as the 101st Airborne. He has deployed to Kosovo, Haiti, Iraq, and Afghanistan. He has a BA from Johns Hopkins, a master's, and a doctor of medicine as well. Very happy to have him here with us today. With Dr. Place is Dr. Leonard Marcus, who is the founding co-director of the National Preparedness Leadership Initiative, which is a collaborative effort of the Harvard Chan School of Public Health and the Harvard Kennedy School, along with the Center for Disease Control and Prevention, DOD, DHS, and the White House. And this I really look forward to hearing more about. He and his colleagues have pioneered development of the conceptual basis for meta leadership, and is going to talk about connectivity and swarm intelligence, which sounds really intriguing. Looking forward to that, and how that relates to leadership in this space. He has a BA from the University of Wisconsin-Madison and a Doctor of Philosophy from Brandeis University. Thrilled to have the two of you here, and I'll turn it over to you for your remarks. First to you, Dr. Place.
Thank you. Thanks to the Bipartisan Commission for your leadership over the years, and special thanks to Dr. George. I think fair to say now a lifelong friend of mine. We met in college many years ago, for her invitation to join you today. Frankly, it's a little interesting to be talking to you about leadership. I'll just comment that perhaps a more meaningful discussion would go the other way, but nevertheless, I'm honored to be here and look forward to our conversation. In line with what Governor Ridge had to say, Senator Daschle, it's good to see you again. I'm a lifelong South Dakotan, born, raised in, and for the duration of my military career, a resident of the state of South Dakota. So there's so few of us around, and good to see you. So I'll keep my opening comments brief, but as a lifelong military physician with considerable operational experience in multiple theaters and with some time in special operations, chemical, biological, radiological, and nuclear weapons have been a nearly continuous concern for me throughout my career. Now, as I contemplate my experiences as a newly retired general officer, I would describe my biggest concern for biodefense as one of bias. Probably not what you expected. In particular, what we call preservation bias. And that, in this case, it's because so many of us are mortified by the consequences of these instruments and find it difficult to conceive of their use. We conclude that others would also not employ them despite ever-growing evidence to the contrary. My professional experience leads me to believe that our adversaries are potentially and even probably analyzing our COVID-19 experience and considering the best way to employ these agents to simply disrupt our society, impair our response and support of allies and partners, or as a means to generate additional resource dilemmas in a time of crisis or conflict. Our biggest challenge is to overcome our biases and truly engage on this important topic. Therefore, I look forward to our discussions this morning. Thank you.
Well, we at the National Preparedness Leadership study leaders and leadership. And so when we see leaders and we see people leading, we know it. So I want to thank each and every one of you for leading on this topic. It's a critically important topic for this country. It's a critically important topic for humanity. So thank each and every one of you for your leadership. Back in 2003, the federal government approached Harvard and sat down with David Gergen, who at the time was the director of the Center for Public Leadership, and me, to establish a platform at Harvard devoted to leadership. Sadly, as many people know here, we lost David just about 2 weeks ago. And not only did I lose a great friend and colleague, the country lost an important voice for reasonableness at a time when we so badly need it. David and I, as we looked out at the scenario facing the country, recognized that there was a lot of change going on with organizational charts. And you remember the Department of Homeland Security was developed. There were a lot of other connections and new charts that were being formed. And what we recognized is you can change the organizational chart. If you don't also change the leaders, what the leaders will do was get very focused on their silo, get very focused on their budget, their authorities, their responsibilities, and not see the bigger picture. So we became devoted to helping the government and helping leaders to see that bigger picture. We did so by being with leaders in times of crisis, studying them, what worked, what didn't work, and what could work better. So out of that, we recognized the importance of seeing the bigger picture. So we developed a model called meta leadership. Meta leader will look at very, very widely what's going on here and what needs to be done about it. Most models of leadership, and it's very specific and appropriate to this question that we're looking at today. Most models of leadership have the leader on top, and there's a pyramid of people underneath. And they all report down, they report up within that pyramid. We recognize that when we're looking at novel threats, such as bioterrorism, biological threats, that we have to have a different orientation to being able to identify the problem, to figure out what needs to be done about it, and then to bring that coherence that's required in that kind of an event. So we started the study of leaders and crises on the notion of complexity. There aren't any easy solutions. There aren't any easy ways of understanding what's going on, building surveillance, building detection, building coordination. So it's complex. So you as a meta leader have to put yourself in the middle of that complexity to understand what's the situation that we're dealing with. So we put the person of the meta leader right in the middle of that scenario. And the better you're able to identify what's going on, what needs to be done about it, and then being able to communicate effectively across a very, very wide spectrum is absolutely critical when you're leading in this field. So building connectivity of effort was the puzzle that we pondered as we put together the meta leadership model. And in building that connectivity of effort, you have to lead in multiple directions. You have to lead down to the people who call you boss. Very importantly, you need to lead up to your boss. And one of the things that David would always say is a crisis or a disaster is not partisan. However, an elected official will live or die on how well they respond to a crisis. So leading up and being able to engage your president, your governor, your secretary, your mayor effectively was an important part of the meta leadership model. You have to lead across, and that's where building that connectivity among all the different agencies, not only within a Department of Homeland Security, out to other agencies, CDC and DOD, that have equities in any kind of a scenario. And then finally, you need to lead beyond. And one of the interesting things we found is that organizations outside of government, such as the business sector, the nonprofit, the humanitarian sector, faith-based organizations, wanted to be part of the action. And as we were watching meta leadership being practiced in the field, what they would say to us is, well, nobody ever asked. We want to get involved. We're an important resource for you when you're thinking very broadly about crises and disasters. The most important element, and here the meta leadership model is built on game theory. And the whole premise of game theory is if we're working against each other's interests, if we're competing with one another, and many government agencies do compete with one another, if we're competing with one another, all the time and effort is invested in trying to win the competition. If, however, and there's a lot of research at Harvard on this topic, if we're oriented towards collaboration, really working together, we can accomplish a lot more. So the theoretical basis of meta leadership is game theory. And this orients every one of the key leaders to how can I help make you a success? And the responsibility of anyone practicing meta leadership is oriented towards mutual success. That's an absolutely critical principle in the topic we're looking at today. So I want to give you a very quick example from COVID-19. First, I'm going to give you some of our background research on the Boston Marathon bombings response. We live in Boston. The Boston Marathon bombings literally happened in all of our backyards. We knew the leaders very well. Many of the leaders had been through our National Preparedness Leadership Initiative training program. So we were involved in the research very early on. And what we discovered in that event was collaboration and cooperation as we had never seen before. Governor Deval Patrick was the perfect political leader in the midst of that crisis. The different agencies worked together very closely. And we believe it's useful to understand instinct as part of understanding leadership. And we humans are social beings. And so through that lens, what we discovered to explain the collaboration of the leaders during the Boston Marathon bombings, 5 principles. The 5 principles were unity of mission. It was all about save lives. And if you, as a meta leader, are able to get everyone on that same mission, just imagine how much you can accomplish. The second principle is creating generosity of spirit and action. It was amazing what was seen right after the bombings. People thought there were going to be 2 more bombs. There were 4 planes on 9/11, 4 bombs in Madrid, in London, 2 bombs went off. They thought there were going to be 2 more bombs. They ran out on the street to pull people off the street. So generosity of spirit and action throughout the event. The third, there are many different agencies, organizations there. Everybody stayed in their lane and helped others succeed. The fourth principle was no ego, no blame. Nobody got up and said, we succeeded here because of me, and nobody was going around and pointing fingers. And the fifth principle was a foundation of trusting relationship. These leaders trusted one another, they knew one another, and they were able to create an extraordinary collaboration. And so we developed, out of our research, out of our interview notes, these 5 principles. We went back to the leaders. I went back, for example, to the FBI special agent in charge, and I said, this is what we came up with. And he said, Lenny, I didn't know that we were doing this. It describes exactly what we were doing. Fast forward to 2020, and many of our NPLI alum, and the way we get involved in these crises is we get in touch with our alum. So I went down to the CDC twice. The Homeland Security Advisor to the President was an NPLI alum, Admiral Pete Brown. I went over to DHS, met with the people there that were involved with the crisis. What we were able to identify was a clear leadership vacuum as we were heading into COVID-19. So I knew the FEMA administrator very well, Pete Gaynor, and I went over to FEMA headquarters. I sat down with Pete, and I said, Pete, based on my analysis, you're going to end up leading the COVID response. And he said, no, I'm not. And I said, yes, you are. He said, look, I do floods, hurricanes, tornadoes. I don't do pandemics. I said, I get it. I'm not saying this is the best thing to do. I'm just saying there's a vacuum. I predict you're going to be the leader of this response. So, of course, March 13th, a president declared a national emergency, put Pete in charge as National Incident Commander. The next day, he called me up. He says, okay, you were right. Let's do this. And so for the first 4 months of COVID, Pete called me every single night. We reviewed what was going on. He was practicing meta leadership. We were talking about implementing these meta leadership tools into what he was doing. And as you all know, about 2 weeks in, there was a huge crisis in New York City with a ventilator shortage. And Mayor was very, very concerned, a lot of concern in the press. And so what I said to Pete is, Pete, what you need to do is to create all the governors into a swarm. You might remember in the early days of COVID, the governors literally had state troopers at the border to prevent outsiders from getting into our state. It was my state versus other states. So there was a real adversarial tone. And what Pete did is he got all the governors on the phone, and we talked about this beforehand. What he got them on the phone, and he created them and turned them into a swarm. Unity of mission, nobody dies in our country from lack of a ventilator. We're all going to give up our ventilators, and if you need a ventilator, you call me, I will get you one that afternoon. Everybody, stayed in their lanes, shared information, helped others to succeed in the state nearby. It was no ego, no blame, a foundation of trusting relationships. Interesting, one of the first things I told Pete is that he needed to stay off the podium. You remember those press conferences? And he did. And the reason was so that his work would be seen as nonpartisan and the governors could trust him. So he implemented those 5 principles among the governors, created the governors into a swarm, able to share those ventilators. And what was really interesting afterwards, you might remember that the governors started creating regional alliances. There was the New England Alliance, there was the West Coast Alliance. The governors became swarms, and we were working together. So just one example of how these principles and practices of meta leadership can be used in the field, especially when we're facing a novel, unpredictable, and complex event, such as any kind of a bioterrorism or bio event. Thank you very much.
That's great. Thank you so much. I will say the terminology, a swarm of governors, like swarm of politicians, sounds like the stuff of a horror flick.
I know.
But the way you put it, it captures the idea just right.
Go.
So thank you for that.
There you go.
So I get the prerogative to have the first couple questions. So Dr. Place, you put it out there as a teaser, bias. Run with it if you would. Tell us the role that bias plays, how you've seen it play out in past situations in the bio space, and what should we do about it?
So I think bias, regardless of what the topic is, we could focus on biodefense or Soberni in general, but the challenge is to get people past the emotion because they shut down and they don't receive information any longer. So it has got to be a continued, calm, reasoned, rational, and to say that we have the means and a process to have an outcome that is viable, it's survivable, there are things we can and should be doing, to emphasize those to get over the challenge of your mind thinking it through. Probably a good analogy, again, as a medical physician, I would just tell you that having people accept their diagnosis, whether it's high blood pressure or diabetes or whatever, obesity, the concept that I have a problem that requires activities and thought process and so forth, that's always the challenge, which is why you see things like AA, where they'll say, hello, my name is Mike and I'm an alcoholic. The actual commitment to saying that I have this problem, but there's something that we can do about it, that's empowering. So the constant or routine delivery of the message, as this commission has done based on the products out on the table out there, incredibly important. But we have to follow that up with, there are things that we can do to mitigate the risk, to improve the outcome. That's when people change their perspective.
Let me ask you, though, about the specific bias that you referenced, the bias that we have that since this is such a horrible specter of a bio attack and the death and destruction would be so horrible, since we can have that reaction to it, that everybody else would have that reaction to it, including our adversaries, and that would make them reluctant to use a bioweapon. I think that was the bias
Right,
that
it's
you
belief
identified.
preservation
So
bias.
I guess what is your take on how that has played out in terms of our biodefense policy in the past, and what should we do to counteract it?
Well, I think many of you have lived this dream, right? As you talk to people, it's like the response is usually, at least in my experience, relatively dismissive. Well, it's just going to be what it is. There's nothing that we can do about it, when the reality is that there is. So I would tell you from my military experience, I've engaged commanders where, potentially we're going to be operating in conditions that are not, that are nuclear or radiologically contaminated. Okay, what are we going to do? Well, people will just die. Well, that is a course of action, but there are actually things we can do to mitigate that, and they're not necessarily resource intensive, or not as resource intensive as you would believe them to be. So you have the conversation about what can be done, the mitigating factors, the countermeasures that can be employed and so forth to preserve the force from a military point of view and to be able to operate in those environments. For us, it's much the same in biodefense. Yes, bad people could do bad things, but there are things we can do to prepare for that are going to prevent some of those consequences. We may not be able to save everybody, but we can save lots more if we prepare properly. So from my perspective, overcoming just the cognitive challenge for people is the critical step in changing the dynamic. It's a leadership task to help people conceive of a different future. That's what you're faced with or we are faced with in this particular space.
Okay, so as you articulate, it sounds sort of more like a sense of fatalism. It's like, okay,
Indeed.
it's going to happen. There's nothing we can do about it.
Correct.
Do you find that to be uniquely prevalent in relation to the bio threat as opposed to other threats where we might not be so fatalistic and we think that we might be able to prevent them?
So I think this is more difficult because people have a difficult time of conceiving it. That's what makes it so hard.
Oh, I see.
So exposing them to the idea repeatedly and then addressing the outcomes, that's why it becomes important, because it is, again, as a bias, it's not based on reality, it's not based on rationality, it is a scare, it's an emotional reaction that diverts them so that they can't think the problem through. That's why it becomes a challenge, it's because the mind closes off to the possibilities. So that's why the work that you do with the publications and so forth becomes so important.
Well, thank you, because that was what I was going to end with. That's one of the, I think, the centralizing rationales for this organization, sort of to keep people conscious that that threat is out there and we can't ignore it based on that sense of sort of fatalistic bias. Okay, thank you for that. Dr. Marcus, so you talked about meta leadership. You used as an example the Boston bombing and then an allusion to 9/11. And both of those are crisis situations. So where you had a crisis that pulled everybody together. And those of us who lived through 9/11 certainly saw that on a national scale, like what you saw in Boston on a regional scale. What about that kind of leadership when you're not in a crisis environment and you don't have that centralizing influence of the post-crisis situation? How do you impose that kind of leadership, for instance, within the federal government? Because you talked about how each leader should have generosity of spirit and do these things. How does somebody in the federal government force all the leaders to take that tack?
It's a really important question. Thank you. So when we put the model together, we said practice meta leadership on a day-to-day basis, and when the crisis comes, it will be ready to be implemented. And so just for example, on swarm leadership, as we've observed our students, as we've studied this phenomenon, leaders are able to use that as part of just day-to-day. And I'll go very briefly to say, we humans are social creatures. So you might have had experiences of being in a swarm. Some people describe their extended family like we're a little swarm. We really take care of one another. Or parents, kids on the soccer team, we really look out after one another, and they find these principles. So it's possible to find principles of swarm leadership in our just day-to-day existence because we're social beings. It comes to the fore when you're in the middle of a crisis, and the chances of it rising to the occasion in that crisis are greatly enhanced if you've been a swarm up to that point. And the other point is it's difficult to convince people when it comes to preparedness and readiness for some sort of biological threat to engage, to make the right decisions, to be ready to go. I'll just simply say, by way of background, when we began our work, we had a lot of students. I have a lot of students from Israel. So we got our grant. I went to Israel. They literally opened up what they were doing on bioterrorism. This was October 2002. And I issued a report. It played on NPR. It got a lot of attention. Basically, it said, this is what the Israelis will do if there's a smallpox attack. If they see one case of smallpox anywhere in the world, day one, they'll get their system moving, and in 3 days, they can vaccinate their whole population. And they showed me the system. They showed me how it would work. They showed me they were vaccinating groups. I put it into report. The report's still out there on the internet. Well, the head of the Office of Terrorism Preparedness and Emergency Response at the CDC at the time, Joe Henderson, got a copy of the report, and he got in touch and said, can you take me to Israel and let me meet with the people you met with? And so January 2003, this is just before that second Iraq war, Israel was very concerned that there would be a preemptive biological, non-conventional attack against the country. It was really interesting seeing Joe interacting with Israeli colleagues and recognizing this actually could happen. And one of the problems, going back to your question on bias, and this is a critical responsibility of a leader, to be able to look at a real worst case scenario and say, this actually could happen. Are we ready? Are we prepared? And I would argue on the topic we're focused on today, we're not ready, we're not prepared, and we're not able to recognize the reality of what it could be if it hit us. And certainly when we were there, Joe and I were there in January 2003, the Israelis were confronting that reality. And he helped then bring that back to the United States. This is not something theoretical. It's not something that, we're spending a lot of money on. This is a reality. And that overcomes the bias that I think is critical in your prior question.
If I could comment on that briefly, one of the things in the military that we do when we do war games is we design the war game to address the most likely and the most dangerous course of action by the enemy. And so that really brings out the themes in a non-crisis period of time to be able to address the issues that you're almost certainly going to see. At least we'll highlight the themes of the challenges. That changes how you approach things in a non-crisis point of view. It sets you up to think if it's the most dangerous, okay, we know how bad it can get, but these are the things that are most likely, and we can set up systems and processes and intelligence and all the rest of it to be prepared for those things specifically, and they're quite informative.
Okay, thank you, gentlemen. Donna, any questions?
Fascinating discussion. General Place, the military, the term unity of mission is also a military term. In fact, the military has a culture that's guided by that. I'm not sure we would have gotten Operation Warp Speed without the leadership of the military, actually in combination with HHS, but it was really the military that knew how to get things done. But the military has also used its culture to for the trauma units, where it literally put together other services, medical services, in a trauma unit and trained them together. So there's something about the culture of the military and leadership training in the military. And I was wondering whether you could talk a little about that culture in our military and what a difference it makes.
Yes, ma'am. So a couple of things come to mind specifically about that. We are obviously trained to think perhaps differently than others. I think that would be fair to say. But unity of command and unity of effort are two different terms that we use in our doctrine to talk about, yes.
I'm not sure you use generosity of spirit.
No, that generally is absent. Indeed, but those concepts drive within the organization that you have formal authorities over a unity that is directive in nature to execute missions. But once you start adding allies and partners, all of a sudden it's universal. It becomes a mission focus, and you have a unity of effort as opposed to a unity of command. So that you get more people on board in the meta leadership sort of perspective to have them do the things that they can do to be helpful. So the lesson is to understand which part of the system that you're operating on. Are you part of a NATO mission where we're all doing some things in order to achieve something together? Or is it something that literally I am executing on my own as a directive for my organization? Many of our civilian colleagues don't have those experiences, and then differentiating between the two of those. So I think ultimately when you're looking at the selection of someone or an office or a position to be in charge of this, it becomes helpful to have someone who has at least in my perspective, a military background or a experience that allows them to see the difference. Because some things you can direct, some things you can't. You can only influence, and understanding the difference becomes critically important. As a related note, I would just say that the United States Army has changed its leadership doctrine in my time in service. A lot of comments before about command and control. It was all about being in charge and, I'm going to say things and people are going to do things and so forth. And people would recognize that for historical purposes. That's how an army is run. But we've changed our doctrine over the last 10 years to something that's called mission command, which is based on shared understanding and trust between leaders to make sure that we have unity of effort to achieve the mission. So we actually have gone further away from the control piece and more to a unity of purpose with command, really to be able to see what we're doing, to give feedback so we can change real time, which is really what drives us to achieve the mission. Thank you.
Yeah. Dr. Marcus, I appreciate your comments about David Gergen. He was a great friend and an important leader, not simply in communications, but just in our society. Could I ask you about how I appreciate the example of Israel, but it's a relatively small country.
Right.
The challenge we have in bioterrorism is we have multiple agencies, we have federalism, and bringing all those units together for preparation as opposed to action on a specific thing is very complicated. Yes. Could you talk a little more about mixing different cultures and different responsibilities to build a strategy and how you view that?
Well, first, thank you for the question. And David was a big fan of how the military looked at leadership, and that was exactly the direction that he was hoping the military would go. So, and I agree with you, a real important voice and friend to many. In terms of being able to bring different cultures together and different perspectives together, that's the essence of what meta-leadership tries to accomplish. And so this orientation that there will be different levels of expertise doesn't mean that those different areas are competing with one another. That the fact that there are differences actually is a plus through the lens of meta leadership. It's one of those differences. I'll also say that the NPLI, because of our graduates who do stay in touch with us, thank you, Asha, and because we're out in the field, we had a very unique perch on the leadership through COVID and up till today. Again, I was speaking regularly with Mr. Gaynor as he was leading the COVID national incident response. And then, of course, we had colleagues in the Biden administration. Ashish Jha is a long friend from Harvard. He was a COVID coordinator, and then continued on even until with current people who are part of this response. And out of this, we recognize that it is going to take a unique mix in order to respond today if there is some sort of a bioterrorism or biological event confronting the country. And so we've recommended what we call the public health rapid response teams that can accomplish, Secretary Shalala, just what you have talked about. Groups of people from different perspectives, a little bit like a firehouse, that have trained together, that are oriented together, and are ready to respond in a moment if there's any signal of a biological event, whether it's an intentional, an adversarial, a biological event by an adversary, or if it's an infectious disease, a pandemic, that a team of people are ready to go. Because that team is ready to go, just like the fire department, they don't start training, they don't start working together, they don't start recognizing their differences and how they come together after the alarm has come in. This is people that are oriented to do so right from the get-go. And because of how this administration, in its first iteration, responded during the pandemic, this should be fit how this administration would handle a biological event in the future. And so recognizing all of this, including intense study we did of Mpox, this public health rapid response team, we believe, would be a format that could work now, could work in the future, because it brings together the different agencies, it brings together different orientation, brings the military together with civilian, it would bring the government together with the business and the nonprofit community. And if you get these people together beforehand and create that team, build the swarm before you need it, should we have a required response or should we have to do intensive surveillance, we're ready to go. And I think that's one of the biggest things that's missing on this topic. We have to ask ourselves, if something were to happen tomorrow, are we ready to go? And I would say, as I said back in 2002, the answer was no. I would say today, I don't think so. I'd be interested what other people on the panel believe. And I think we as a country need to be ready to go, whether it's the act of an adversary or whether it's the act of nature. We're vulnerable. And I think this group of people, this commission, I think is critical in being able to articulate just what that vulnerability is and what can be done to address it.
Thank you. We do have an overflow room for anyone that doesn't want to keep standing. 208?
608.
608?
608.
608. 608.
Okay, thank you, Donna. Governor Ridge, as a man who has exercised leadership in very many contexts, from combat to the highest levels of the federal government, love to hear any thoughts or questions you might have about this leadership topic.
Well, I had no particular questions. I particularly appreciate the insight and perspective by our witness. And question I've be interesting for him to, is there such thing as a born leader or do circumstances create one? You talk about a meta leadership. Can you create good leaders or is there something internal to an individual that allows them to come forward and become the leader that either the unit or the country needs at the time?
Well, speaking of bias,
Should it be taught?
what? Sorry.
It has to be intuitive.
So I'll acknowledge my bias, and I think I shared this with David. We're both educators, and we believe that it's possible, if someone has the passion and has the commitment, it's possible to teach one how to lead. Everyone who is taught will be a different kind of a leader. So it's not a matter of one format of leadership. We certainly believed in our work with the NPLI, with the National Preparedness Leadership Initiative, that in fact, different expressions of there within the government, within the business sector, within the nonprofit, faith-based, bringing those people together and getting them on the same page when it comes to surveillance and considering what threats face the community, when it comes to what would we do if it were to come to our community, and then coming together in the midst of a crisis, we think is very powerful. And there's not one format for a leader. And one of the most exciting things I've been able to discover through this work is people who first came and were shy, were quiet, and then in the midst of a crisis, they're the ones that stood up and they're the ones who led. So, Governor Ridge, I would say that the key thing is whether you want to be a leader and whether you have the passion to be a leader. If you've got that, then we're happy to provide the education.
I very much appreciate your answer, and we'll look forward, perhaps on a more personal level, and following up with you on this whole question of leadership. I've had the benefit of being in the military for almost 2 years, and can say that the United States military is pretty darn good at assessing capabilities. The cream rises to the top. Leadership seems to evolve quite naturally within our military. At least I was the benefit of having some particularly fine leaders in my time in the military. And I like to look back and say, hopefully I provided the same kind of leadership to my team as others provided for me. So I appreciate this conversation, and I look forward to a more personal conversation on the question of leadership with you in the near future. Thank you for your participation today. Hoorah.
Thank you, Governor. Tom Daschle.
Well, let me just let me express, as the governor just did, our gratitude to both of you for your service and for your wisdom today. I've appreciated this conversation a great deal. I would just ask, just to build a little bit more, drill down on Secretary Shalala's questions about our experiences in leadership with COVID. As you look back, what are the lessons to be learned from the leadership structure that was created in reaction to the COVID crisis? What can we learn from that, and how would we apply it going forward? And let me ask both of you the same question.
So I would just, I guess, offer that perhaps most importantly was the mix of both civilian and military in that. Because from at least my perspective at the time, having the combination of those who understood the political realities as well as affiliations outside of the DoD were incredibly important to help the country run that properly. The kinds of officers that went there, and I know most of them, many of them were from the Army. In fact, several of them were within my command, were actually working for me, and then they weren't. They are the people who can get things done, know how to task organize, know how to prioritize, know how to, no kidding, get it across the finish line. So the combination of those two, to me, was what made it work. Obviously drew on a lot of expertise from the scientific community and so forth, but they had the leaders that both understood the politics and understood the execution, working hand in hand to generate rapid change. I guess the other lesson I would say from my perspective is that we have the capability as a country to overcome many, many challenges. However, the idea that we're going to, be the hero, the action figure who comes in at the last minute and saves the day, is not likely to serve us well in the long term. So to me, the biggest lesson is that once we acknowledge that we have these challenges, we have to be successful in a long-term investment strategy, as opposed to thinking every single time we're going to be successful. Because for all of us in any mission, the inability to actually get it done because of what other constraints we have, the consequences are profound, arguably even existential. So I think it's important for us to go back and say, look, we have to set up systems, processes, make the investments. In my estimation, we have not done that. We are not putting in place those things that are going to allow us to be successful most of the time. You can't ever guarantee all of the time, but most of the time to be successful in this process. And I continue to see our investments dwindle, and particularly in the science and technology portion of this, which are going to be critically important in the future. So I'll stop there, but I think there's a place to start.
Dr. Place, thank you for such an eloquent answer, and coming from a South Dakotan, I doubly appreciate your eloquence. But let me just ask, you've used the word successful now several times in your wonderful answer. I get asked the question somewhat, not as much as I used to, but I used to be asked the question frequently, was our response to COVID a success or failure? 1 million people in this country died. It's hard to acknowledge that and say somehow we were successful. How would you view the overall effort, not only as it relates to leadership, but just the response? It was a bipartisan situation. We had a Republican and a Democratic president, so there's no blame to be spread here. It's bipartisan in both success and failure contexts. But how would you answer the question?
Well, first, we're products of Lake Wobegon, right? Everybody's above average. So I guess what I would describe it as is, given the circumstances, we were wildly successful. We demonstrated by coming together to truly have our COVID moonshot, whatever you want to call it, that we're able to accomplish incredible things and save millions of lives as well. The question really overall, though, is, okay, knowing that, what could we do to lose less of those million lives? And in that sense, I would say we were not successful. So to me, it's not an either or. They can both be true at the same time. So yes, it was both successful and unsuccessful simultaneously. And what we're arguing now is that in the future, we ought to set the foundations so that success comes much more easily and much more rapidly to a potentially much more dangerous agent that might be facing us.
Thank you, Dr. Place. Dr. Marcus, let me just ask the same questions. What lessons can we apply as we consider the next threat, whether it's a pandemic or something man-made? And secondly, how would you characterize the overall COVID experience, success or failure?
Okay. So thank you for the question. Sometimes it's useful to do a comparative analysis to answer that first question, and I would compare how the country dealt with H1N1, swine flu, as compared with COVID. And what we found in studying the leaders during that, of course, this is back in 2009, is they were very, very focused on the facts and pulling in information and adapting what they were thinking and doing based on the epidemiological information that was coming in. They took all of that data and then tried to understand what are the trends going on here. And they were very open to discovering new trends as they went. And as we studied them, one of those trends was they discovered that pregnant women were particularly vulnerable to the disease. And so with that, they could recognize, they could predict that if there wasn't specific action regarding pregnant women, there would be a lot of cases for that subpopulation. So what they did is they decided to call a pregnant women's campaign, in which they were educating doctors, they were educating the community, they were educating pregnant women, big media push to get that out with a whole set of new protocols that were appropriate to that particular problem and a lot of communication. And so that's a great example of leadership. We call that in the meta leadership, the tool of that is called the pop-doc loop. Perceive what's going on. Be really aggressive about getting the facts. Really aggressive about even questioning whether you're interpreting the data correctly. So you've got to be willing to even ask yourself tough questions, finding what the trends are, and then with that, where are we headed? And as a leader, you're not dealing with the operation of today, you're dealing with what's going to happen next week, next month, 6 months from now, because we've got to be prepared for that, because we know we're on a trajectory, and then make decisions based on the data, operationalize those decisions, communicate out, and then pull in a lot of information to see if you're in the right trajectory, and then shift your strategy, shift what you're doing on a daily basis. And we observed the CDC doing that during H1N1. There was good communication with elected officials, not perfect, very good communication with elected officials. And as we were studying the leadership of the COVID response, we were comparing it to H1N1. Regarding your questions of failures and success, there are many extraordinary successes. Operation Warp Speed was a great success. Just to take one example, masks, not a success, because the communication wasn't clear about masks, the policies were not consistent about masks, the science, there were a lot of questions about the science regarding masks. So I would say that ambiguity, in the middle of a time when we were all very, very worried, and we're worried for ourselves, for our family members, etc., that's an example of a failure of perception and facts and data, failure of communication. And then all of that ambiguity created not a sense of swarm in our country, it was a sense of division. And that, from a leadership perspective, was one of the failures.
Thank you both. Ken?
Okay, Pig Hamberg.
Hey, may I intrude to say a word to General Place?
Sure thing.
Beat Navy.
Hoa.
Thank you for that. All right.
Okay, well,
Peggy,
I
top back.
have no particular sports insights or enthusiasms, I'll admit, in terms of this panel, but I am very interested in the comments that you made in so many domains, a lot of questions I'd like to follow up on. One sort of builds, Dr. Marcus, on what you were just saying about, part of the role of a leader is not to respond to the crisis at hand, but also to be looking down the road. I guess a sports analogy does come to mind,
Yes.
skating to the puck,
Yes.
where the puck will
Exactly.
be, not where it is. And, two issues have been mentioned where I think, we need to sort of look at how things build over time and appreciate that. One is, of course, Operation Warp Speed, where that could not have happened if the investments in fundamental science had not happened and there hadn't been an appreciation, not just of that investment in fundamental science, but the possibilities of its implications in different contexts, including this kind of an emergency response, and the ability to work across sectors, government, academic research, and the military, as Donna pointed out, played a critical role. The other was your smallpox story, which I had to reflect on because when I was an assistant secretary serving under Donna Shalala, pre-9/11, pre-anthrax letters, we actually were developing a biopreparedness program and let the first contract for smallpox vaccine for civilian populations at a time when, most people were not thinking about the threat. And, Donna, showed great leadership going to the president and explaining why some of these investments were so important and educating the public. And also, there was a tabletop, a war game done, Dark Winter, that helped to deepen understanding. So, what I was thinking about was how do we train our leaders and work as public officials or other important leaders to really engage policymakers and the public in understanding the issues so that we can have the ongoing investments and the collaboration across administrations that's necessary. We are so driven by, frankly, election cycles now. We're seeing also the challenge of so many competing priorities, but what really makes a difference is both having the leadership that is capable of stepping up in a crisis, but also the foundations for what's needed for leaders to be able to have the tools in their toolbox when the crisis occurs, and the public support for all of that is vital. So, the military has one way of approaching some of this with the kind of strategic planning and exercising that you do all the time. I think it's a little more challenging in the civilian sector. Thank you.
Oh, may I answer the question? Just very briefly, it's important to teach leaders imagination. Apropos of the topic of today, in terms of understanding a situation and understanding what we're going to have to do if that scenario were to evolve. And it's not only to be able to have an imagination, it's to be able to communicate imagination. So in speaking with policymakers, it's being able to ask the question, what if this were to happen? Are we prepared? And that what if requires an imagination, because we don't want to think about a biological attack. And yet it's important for people to look at that, and then a whole series of other threats facing the country, from floods and tornadoes and hurricanes to a pandemic. And it requires an imagination, because we would prefer not to engage in those possibilities.
But just to follow up on that, it requires imagination, but it also requires communicating the legitimacy of the concern and the importance to people, and the importance of policymakers acting on those public concerns to enable the appropriate context for action.
Absolutely. And so, and that first step is to engage the imagination, and then come in with the facts, come in with the options, and come up with the actions that evolve from that. But on the topic of today's conversation, it's hard to imagine that we would have an event that would require a biological event of this nature, just as it was hard for us to imagine a pandemic in 2020 that was similar to what we had experienced almost a century before.
Okay, thank you. Fred Upton?
Well, thank you both. Thank you for your service and welcome home, as they say. Just a couple of comments that I have. David Gergen was a friend. I engaged with him. I was in the House, in the Congress 36 years, so we had a chance to engage together on a number of different issues. And I was actually in Boston, and when you raised that, my daughter lived in Boston on the route, in fact, and I was in Boston that week. So I saw the community really coming together. I only wish I had gone to that Boston Red Sox game that Sunday. But a couple questions. As I think about the Kennedy School, and I participated, I think those are really good lessons, particularly in this day and age. We saw with COVID a Congress that did come together like we did after 9/11 as well. I mean, you look at the votes that we had for the PPP program and other things, and widely bipartisan, often 380, 390 votes as we tried to get out of that. And it was very personal because we all lost people, friends to COVID. I guess, General Place, I know I'm actually glad that you're retired, in that you might be able to answer this question maybe better than if you had OMB down your neck or somebody else. But as you did these tabletop exercises, and again, I participated in some, where are we in terms of having a response team that was referenced when we face this crisis again? where are we in terms of your influence, or what are your thoughts as it relates to the stockpile? I presume that you had some influence on that, and we know that there are real shortfalls there, to make sure that we are in fact properly prepared for the consequences that may come about.
Yeah, thanks for the question. Yes, without talking in classified language or anything like that, I think it would be fair to say that we are reasonably well prepared. And I'd just kind of leave it there. I do think that there are things that we ought to be doing in a variety of different topics. What I would refer to as intelligence. Do we have an active biosurveillance methodology for the nation? I think the answer is no. If that's the case, that would be critically important in generating the time for decision space for senior leaders to be able to say what we ought to be doing and how we're going to approach the particular problem or challenge in front of us. I think identifying and regionally aligning our stockpiles would be incredibly helpful and make them much less susceptible to damage and whatever else may happen. I think that's important. I think the investment in science and technology is also critically important in this process. So perhaps the best way to describe it, in my mind, for both your question and for Honorable Hamberg's question, as a physician, taking care of heart attacks, there's a phrase that we use, which is time is muscle, the heart muscle. The longer you wait to be able to decide, more heart muscle dies. In military medicine, as many of you are aware, the time from evacuation from injury to getting to a surgeon for combat trauma, that time is inversely proportional to outcomes. The longer you wait, the worse the outcome is. I would offer for your discussions with colleagues and leaders across government to say, listen, the longer we wait, the more people will die. It's not theoretical, that's how this works. If it takes us 2 years to develop the COVID-19 vaccine as opposed to the months that it did, more people will die. It's math, it's science, it's hard, it's facts. It's not supposition. So I guess what I would offer is that we either take actions to properly prepare for those things that we believe are the most important within the budget constraints that we have, or we accept the outcomes. And then it's a matter of senior leaders. Not everybody will be on board. Politics does play a role, of course. Yet I still believe, and perhaps there's some naivete there as a uniformed person, that there are people, good people like you, who want to make a difference, that want to change the course and the outcome to save lives.
Thank you.
Okay, we're running up toward the end of the hour, but Susan, any questions? Susan Brooks?
Very briefly, thank you, and thank you so much for being here. Dr. Marcus, you talked about it, but I think General Place, you've lived it when so many different agencies change. And that is what we're experiencing right now with so many different agencies in our government changing. What kind of mechanisms and what do we put in place to make sure that biodefense is believed to be one of the most important focal points as our agencies change and as we adapt to the changes? What kind of things should we be encouraging our government to be focused on to make sure that biodefense does, have the highest level of importance, but with so many priorities that the agencies have? What are the best mechanisms and the leadership mechanisms we can put in place to make sure that our government, as it's evolving and changing, move biodefense to the top?
Well, first off, thank you for the work of this commission, because I think this is an important voice for representing the criticality of this issue. Second, I do believe this voice has to come from the Hill and from our elected officials. And I think it has to be part of the training of leaders in government agencies. David and I made this investment in building the NPLI and building this body of knowledge because we believe that leadership really matters. Those were David's favorite words. Leadership matters. And being able to fortify the leadership of these agencies so they're oriented towards working together. And I'd say the biggest change that we find that when we're observing and working with agencies, it's not about my silo. It's not about building my budget. It's about how does what I'm doing fit with what another agency or another component of my own agency is working, and how do we build that connectivity of effort. That's what's required when we're talking about biodefense, because you don't know what's the source of the threat. And sometimes the clues that you're going to get are very, very subtle. That's why it's not only connectivity of the federal government, it's all the way out to states. It's all the way out to communities. It's all the way out to the business community. Who's going to be the first one who picks up that critical clue? And only if we create this web of agencies truly working together, orienting together, and that comes from the mantle of the leaders. If that's what we're doing and that's how we're orienting, we'll be better prepared.
Ma'am, if I might take a moment to comment, and this may or may not be well received, but you mentioned this as the most important topic, and I'm not sure I'm willing to go there. It is an important topic, but it's part of a large portfolio of potential security threats to our nation. Rather than perceiving this as a win-lose sort of thing, I think it would be really important to think of this as something that if we recognize it is important, it ought to be on the priority sheet somewhere, then to allow senior leadership to be able to determine how high a priority. So I think you're there already to say it is a priority, and we're going to have to live with where it falls on the order of merit list.
I guess I'd rephrase my statement. How do we make sure it stays up on the high priority list?
That is a much more important question.
Yes, and how do we make sure we do that?
Yeah, well, from my perspective is to have those conversations and repeatedly have those conversations to educate people on the consequences of not making the decision to make sure it's on the priority list. That's difficult, but it's like the transformation of the Army leadership. If it's all command and control, if it must be, then oftentimes you lose, because then it's a hard decision. It's a yes or no, you're one way or the other. And somebody's going to eventually say no, just no. If it's got to be yes or no, it'll be no. Instead, you want to have it's on the list, it's going to stay on the list, and we'll live with some vagaries in how much it's supported from time to time.
And Representative Brooks, I just want to underline something that Dr. Place said earlier. That coordination translates into time. Time translates into lives. And I think it's critically important that we in this room understand that, and that leaders in agencies understand that as well.
Okay, Asha George.
Okay, I'll go really fast. Lenny, you mentioned earlier the idea of the public health rapid response teams, which I think is a great idea, but my concern is, and not just for this administration, we've been drawing down on the public health workforce for decades now, thinking that, we enjoy such a high level of health here in the United States. We don't, why do we need these people? So with the increasingly limited amount of public health workforce that we have, I wonder how we compose those rapid response teams in that environment. Do you have a solution?
Well, first off, as you know and we agree, there's a critical, almost crisis going on in the public health workforce right now. And we're getting calls from people in the workforce about the losses they're experiencing in terms of budget, in terms of people, in terms of capabilities. Mm-hmm. So the country is in a crisis when it comes to the public health workforce. That's a given. The notion of the public health rapid response teams is in part a response to what would work right now in this administration that could be picked up. And we've had those conversations, and it makes sense in these times. The other thing, and this is a much longer conversation, is we've not quite perfected how to respond to a public health emergency yet. And we're not quite sure if it's ASPR or if it's the CDC, or it'll go ASPR, then the CDC. So there's a lot of ambiguity about how we respond to public health crises. And for sure, we need a team of people that are ready and oriented toward working together, and that can bring the equities of their agencies into the mix without being concerned about who's in charge, without being concerned about who's pushing out whom. And that has to be, that swarm has to be the critical element of this public health response team, because the threats are there. And so in part, it's a response to the ambiguity and the ambivalence that we've had in this country for 2 decades about how we're going to respond to public health emergencies. And we'll only be able to do that. The leaders are not doing all the work. The leaders have a robust, well-trained, and ready public health workforce that can be brought into action, just like the fire is not fought by the fire chief, and the fire is fought by the group of people that are trained and ready to go. Same is true in public health.
Okay.
Yeah.
And my friend Mike, Scooney brother, there is something we've been discussing with DOD for quite some time now, in the last few years, in the previous administration and now in this administration as well. The acronym is LISCO, and for those of you who don't know what that is, it stands for Large Scale Combat Operations. Now, a lot of that discussion is about bombs going off and experiencing large-scale casualties because of that. But we, of course, contend that you could have biological weapons use and you would have large-scale, not necessarily injury, but illness that would occur on the battlefield. Now, the big concern is that, or not the big concern, but the plan, as I understand it, is not to leave all these large-scale casualties out and about throughout the world, at least not forever. But instead, there's a plan to bring everybody back to the United States. But then we have another concern, and that concern is the military hospitals here in the United States and the civilian hospitals are both going to have to work together to treat all those people. And the expertise doesn't necessarily reside anywhere anymore in the United States for biodefense stuff. At this large scale that we would need in terms of hospital and medical response, certainly not in the civilian side. We used to transport everybody to, say, Germany or, sort of out of theater, but still not all the way back to the United States. But we were also privatizing a lot and drawing down on the military medical workforce, the military public health workforce. So again, now even if we were to do that, we're talking about sending people affected by biological agents to hospitals in other countries that also aren't necessarily prepared. Now we're doing this. It's a commonly done thing, I know, to manage. We're managing budgets this way. And we shift back and forth. Somebody will decide here pretty soon that it's cheaper to use active duty military, and we'll swing back over here. And then somebody else will come in and say, oh, we have to reduce the size of the military, and we'll swing back. But we have this situation right now that we're really concerned about. So can you just talk a little bit about this situation, the LISCO situation, possibly with the bio piece included, and what we as leaders can do, not just in that situation, but as leaders who have some influence on policy, what we can do to address the situation so that we're not standing here now looking into the future and saying, well, so we're just looking at hundreds of thousands of troops, airmen, sailors just dying.
So if I might, my second to last job in the Army was to be the commanding general of the 18th Medical Command, which probably means nothing to anybody here. But it is the senior medical command within the Indo-Pacific. And so the tyranny of distance, the evacuation requirements, the infrastructure challenges and so forth, near and dear to my heart. Spent a lot of time thinking through what the implications are for conflict within the theater and how to manage all of those. So one of the conclusions that I've had, based on all of our wargaming and analysis and so forth, that it is at least reasonably likely that either to disrupt our society or to have a resource constraint or to give what we would call multiple dilemmas to leadership to decide, that biological agents may well be part of either a prelude or part of a concerted campaign as part of a conflict. Okay, we'll start with that it is reasonably probable that that could occur. I don't think that's a newsflash to anybody. That's part of what we talk about. With that, you described well, I think, the combination of the very close margin that most civilian hospitals have for bed space that we experienced during COVID, as well as throughout my entire career, the consistent decline in the capacity of the military health system matched against their 10 million people, beneficiaries that they take care of, with a declining or steady budget, not in real dollars, but in actual dollars. We end up with a significant mismatch between capacity and requirements. It will take action to reverse those things. I am not as concerned about the training of medical personnel, because most of the things that we're going to do are consistent with other activities that they do, just like with COVID.
Okay.
Yes, there's additional donning and doffing of protective equipment and that sort of thing, but those can be relatively quickly taught. Okay. Managing a patient in the ICU is managing a patient in the ICU. The principles are the same. Yes, we will learn more depending on the agent and all the rest, but that is a smaller concern, and that can be a just-in-time training sort of event. But the foundations of the capacity of the system are going to be a significant constraint, particularly if the military is otherwise engaged in conflict. Those personnel will not be available, most likely, to augment civilian facilities, and we've already determined by real-life experience that we are constrained in terms of capacity. I hope that answers your
Yes,
question.
thank you.
Okay, Tim Greenwood.
Thank you. So I want to follow up on Senator Daschle's questions about success and failure. Clearly, if you look at warp speed, if you look at the vaccine manufacturers, you look at the doctors, the nurses, the hospitals, the healthcare providers of all kind, tremendous success. On the other hand, instead of this gigantic threat, probably in terms of life and death, the greatest threat the nation has faced in decades, instead of the country, our society, unifying around the threat and assuming that the Faucis of the world and the school boards of the world and others were acting in good faith, erring on the side of caution to minimize the risk, and learning as they went, a significant portion of our society were conspiratorial. They assumed that all of these measures were taken for purposes of control, of taking away personal liberties. And so we ended up with this fairly vicious debate, vilification of many people who did not deserve to be vilified. And so what concerns me about that is that when the next pandemic comes along, that our society will immediately retreat to their corners and assume from the beginning that here we go again, I'm not wearing a mask, I'm not getting vaccinated, don't shut down my school, don't shut down my business. So the question is, how do we inoculate against that now? What kind of leadership is required now so that we minimize the likelihood that the next time around we go right back into the same sort of polarized division?
Sure. Let me follow up from Dr. George's question. I don't want to predict, but I guess I am. I predict that will be part of the phenomenon. When we do our war games in the military, we talk about these cross-domain effects, right? So we talk about air, land, sea, subsea, now space, but information and disinformation is a significant, the cyber world is part of it. And so I would anticipate not only the use of those agents, but a disinformation, misinformation active program to exacerbate what little impact it may have or the impacts that it does have in order to further polarize society and freeze us from responding appropriately. I think it's likely to occur, not by exception. So what we have to do is be consistent in, at least on my side within medicine, to not say or claim more than we know. It's a big responsibility. These are the things we know, and there are things we don't know, and that will change over time. In my estimation, we had many of our senior medical leaders across society do that to be able to describe what we do and don't know. But counteracting misinformation and disinformation, to your question specifically, I think is a critical component of our national security, and we ought to continue to invest there.
In addition to what Dr. Place said, we did a study of Mpox response, so that was like a mini example. And of course, there was a delay in ordering up the vaccine from the national stockpile, and that created a lot of cases that otherwise probably could have been prevented. So here we have a situation. And what was important is that the community reached out to one another and recognized, because we don't have a vaccine right now, what we can do is encourage behavioral change. And so there was a real strong effort at the community level to encourage people to refrain from behaviors that could lead to the spread of Mpox, to help people understand and to support people who are experiencing the disease in lieu of the vaccine. Nobody planned it, and it wasn't part of the original intent. However, it happens. And I think the lesson from there, Representative Greenwood, is that the population has to ally with those people who are leading. The population is absolutely critical to being able to address any kind of bioweapon or biological disease or pandemic. So number one is to engage the public so that we're together. They understand what behaviors are required of them in order to mitigate further spread of the disease. And that has to be one of our first priorities. And that is where leadership comes in, because people will do and act and behave based on the prompts that leaders provide them. And I would hope that leaders at all levels, elected officials, agency officials, community leaders, faith-based leaders, would be on board with the message of only if we take responsibility individually and as a community can we address whatever the threat might be.
Okay, thank you very much. We went over, but that I think is a reflection of how important this topic is and how illuminating your comments were. So thank you, doctors, for your comments. Thank you for your work in this space, and I look forward to continued interaction with you on this very important topic.
Thank you.
Thanks so much.
Our second panel is designed to really drill down on many of the questions that were raised with the first panel. It's entitled Preparedness and Planning, and we certainly have two people who are experienced in preparedness and planning, and we're delighted to have both of them with us this morning. Lori Tremmel Freeman has been the Chief Executive Officer for the National Association of County and City Health Officials since May of 2018. She served as the Chief Executive Officer for the Association of Maternal and Child Health Programs, and as a career nonprofit executive, having joined 3 decades of working in senior association leadership management roles, including the International Test and Evaluation Association. David Stiefel serves as the Director for the NTI Global Biological Policy and Programs team. He served in the White House as the Director for Biodefense, Deputy Senior Director for Global Health Security and Biodefense, and most recently as the Acting Senior Director for Global Health Security and Biodefense on the National Security Council. Mr. Stiefel led President Biden's Biopreparedness Review, which culminated in the President's signing and release of the 2022 National Defense Strategy and Implementation Plan. welcome, both of you. We're delighted you're here. And again, our apologies for keeping you waiting. But Ms. Tremmel, Freeman, we'll start with you.
Thank you so much for the opportunity to present to the Bipartisan Commission today, and it's indeed an honor to be here with you all. NACCHO is a nonpartisan membership association representing the over 3,300 local health departments in the country at the county and the city level. Local public health serves the whole community and focuses on primary prevention. And this can be the difference between preventing negative outcomes from ever occurring versus addressing things later when it can be more costly and dangerous. And this approach to preparedness and prevention carries over into our health security mission for local health departments, where we work to prevent and contain and minimize disruption from and respond to all hazards, both natural and man-made. Local health departments are unique, and they're on the front lines of the front lines, we like to say, collaborating with and co-leading preparedness and response activities with emergency management and healthcare entities within their regions. Moreover, they are key experts on regionalized disasters, helping inform and coordinate the state and federal level support necessary. They're also key conveners in the community, something that is really important when mobilizing multiple assets in a community for response. While communities vary in geography and the resources that they receive and their available supports, their health security matters to all of us. And as pathogens and natural disasters know no borders among communities. We've seen this play out in recent months with the measles outbreaks in Texas that spread to neighboring states, and as well as the hurricane-related flooding inland in the mountains of North Carolina last year. Similarly, the impact of chronic disease and injury also matter, and healthier communities are better and more easier able to withstand health security threats that they may face in the future. That's why investing in local public health, both with financial resources, but also inclusion in important planning and decision-making, is what is going to make it effective and efficient in terms of preparedness and response. Local health departments use federal investments to provide services to families, to keep businesses open and operational, to protect our schools, and to prepare for and prevent costly emergencies. Preparedness is not a point in time, but a continuous exercise in need of a predictable and sustainable effort to create, maintain, train, and update all the players on their roles and responsibilities. Over the past decade, we all know that the United States has experienced some significant increases in the frequency and financial impact of natural disasters. I won't repeat the economic toll, but it's been staggering over the past decade. But just a reminder that in 2025 alone, in our measles outbreak, we had 29 outbreaks to date. It's about midway through the year, about 1,300 cases. We know from cost analysis that each case costs $32,000. We also know that each outbreak costs $152,000. So right now, this outbreak has cost us over $4 billion, and it was preventable. At the federal level, a key partner stakeholder of local health departments is the CDC, with approximately 80% of CDC's budget going out the door to support local and state health departments. The CDC has important technical expertise and runs key data systems and operates critical lab functions that help us all do our work back at home in communities as well. While the Public Health Emergency Preparedness Program is the key funding for preparedness out of the CDC, other funding streams help ensure our health departments across the country have the resources that they need to identify, detect, respond, and host all kinds of different health security threats. The ways that the Public Health and Emergency Preparedness funds support local health departments include maintaining early warning systems to detect emerging health threats, investigating, containing, and reporting disease outbreaks, coordinating countywide health and medical response to pandemics, acts of biological, chemical, or radiological terrorism, and natural disasters. They provide life-saving medicines, chemical antidotes, PPE and other medical supplies to first responders, healthcare providers, and the public from federal stockpiles, and conduct terrorism threat assessments for special events with federal agencies, providing essential information to leaders, first responders, the medical community, as well as coordinating the evacuation of hospitals and nursing homes. The ASPR is another key stakeholder for local public health departments in preparedness and response, including through the hospital preparedness program and those grants. And we know that our local health departments, they act as the convener and coordinating body for about 70% of the hospital preparedness program grants. And these programs are important investments in the country's health as an overall arching investment. Just to wrap up, we are about to release the 2024 preparedness profile at the end of this month. This is our effort to gather information from our 3,300 health departments and the preparedness coordinators that sit in those health departments. Right now, half of those health department preparedness coordinators have 5 years or less of experience in the field. And we saw such huge turnover during the pandemic that this is what accounts for that. A majority spend half of their job duties on preparedness, but for the smaller health departments, these preparedness coordinators have to wear very many hats and do very many other things for the health department and can't focus all the time on preparedness. Nearly 60% feel completely prepared to respond to pandemics and small infectious disease outbreaks. And 70% report having a local stockpile, although many of them do not know how long it will last. And small and rural local health departments are less likely to have a cache of PPE or a range of supplies, and they're more limited. So these abstract data points show that a local health department workforce that is actively preparing and responding and exercising each year to crises that make the news, but not often do they make the news. But in LA, local health departments sprung into action after the local wildfires to set up special needs shelters, for example. Our local health departments are always there for building and resilience and recovery post-emergency. And we saw this in North Carolina, where our local health departments came behind after the flood receded to test individual wells to ensure that residents could return home safely and have a safe water supply to prevent additional threats from post-flooding. I'll just wrap up by saying that we did publish, the global pandemic demonstrated the value of preparedness, just to mention COVID. I could go on for probably the next 6 hours about the preparedness response effort for COVID. But it also showed us that we have a need for localities to tailor their responses directly to the needs of their community. We did publish the results of after action reports in this health security issue that helped us to show the various lessons that we learned and how we might prepare for the future. And I hope that we will pull this out in the future because the next emergency is on its way to us at any time. And then finally, I'll just say, in addition to the planned end of pandemic era supplemental funds that we saw rescinded, the $11.4 billion in rescissions that have had significant impacts on our local health departments, we are seeing other kinds of things that are delaying money getting to our local health departments right now, just slow walking of funds coming through the federal government. The way that money is coming out the door is slower and less likely to get into the hands of our local health departments more quickly. This becomes really important as we head into hurricane. We are in hurricane season, and as we head into the rest of the year, we are also seeing moving forward that the president's budget proposals include significant reductions not only for preparedness funding but for other core funding streams that really create the foundation of our local public health department preparedness and response efforts. And we worry a little bit about the stated intentions of this administration to continue to look at moving resources away from the federal government and putting more control in the hands of state and local governments. But when it comes to emergencies, we know that we need the whole of the public health system, all three solid legs of that stool in place in order to appropriately respond to public health emergencies. And we're not so sure that the third leg of that federal stool is shored up enough to allow us to respond in the future in the way that will help us to save lives and keep our communities safe and healthy. So we worry about that. So as we try to keep our communities safe, we recommend inclusion of local health departments and federal, state data systems and communications around preparedness and response. We would like to focus inclusion of public health at the table in terms of preparedness and response, especially local health departments who are on the ground, along with emergency management and health care. We support emerging technologies like wastewater surveillance that will help us to identify potential issues earlier. And we need stable, predictable public health funding, particularly for our public health emergency preparedness funds, our HPP, and our MRC programs. And we need a functioning immunization program to move towards pandemic mass dispensing response posture as well. We need continued investment in workforce development. And finally, we need the continuation of important work of preparedness science so that we could better understand the capacity of local health departments to acquire and store medical countermeasures. And our national health security relies on our local health department's ability to access supplies and to be able to respond quickly. Thank you very much for your time.
Well, thank you, Ms. Tremmel Freeman. Mr. Stiefel.
Great, thank you. Thank you to the Commission for having me. And since I've worked with them so much, thank you to the Commission staff for all you do. So this panel is on planning and preparedness. And I just want to start by saying this is my first time speaking here, but it is not my first time planning and preparing for a speech at this commission. And I think as Dr. Punjabi can probably attest, now that I'm working at an NGO, the planning and preparedness to come to an event like this, as opposed to when I was at the White House, involved so many less lawyers and communication experts that this was the easiest planning preparedness that I've done. No OMB review. It's been fantastic. And I'm really excited that I don't have to run back over 2 blocks immediately after my panel and sit through the entire event. And now that I work at an NGO, it's hitting even harder about the importance of the work of non-governmental organizations. While most of my comments will be focused on federal executive and legislative branch, I have to say that NGOs can have such an important role in biodefense. Specifically, this organization's reports have been so influential. And I know we've told you this over and over again, but in drafting the 2022 biodefense strategy, this report was on our desk every single day. And as my former students in the room can attest, I only really assign about 10 readings in every semester, and that report is one of those 10 readings. So, to be brief, I have 4 key points related to national biodefense that I think are very important to get across when looking at planning and preparedness and developing strategies and policies. The first, national biodefense does not work without global biodefense and global health security. We cannot protect our own national borders without looking across the entire globe and trying to stop diseases where they are and understand where diseases are popping up. Let alone when you look at plant pathology, you can have a plant disease come from Africa over a trade route and then up into the US via a hurricane, right? How do you stop that without looking globally? 2, everybody wants to focus on deliberate because deliberate is sexy and because deliberate is impactful in the news. But you cannot stop looking at the natural everyday events because those aspects, the planning preparedness for natural events, also protects you for deliberate events. Words matter. I came from USDA. Everybody wants to talk about One Health. I love One Health. But if I ask every one of you what One Health means, every one of you will give me a different response. To some, One Health means all aspects of the system need to work for the system to work. That's what we write on sheets of paper. Those are the words we use. But how people operationalize that is all aspects of the system need to work so humans are healthy. And when you operationalize the words that are not on the page, you lose trust, which brings me to my fourth main key, which is trust is foundational into any planning, preparedness, and then implementation. Agriculture needs to trust public health. Public health needs to trust agriculture. The population needs to trust the government and its practitioners. The government needs to trust the population, trust science and data, and implementers must trust that at some point the government will set a goalpost that has some consistency that you can plan to arrive at that goalpost. When you're creating policies and strategies, departments and agencies of the government must also trust the processes in which those policies and plans are developed. The processes need to be inclusive, transparent, predictable, and deliberative. If you actually want a strategy to be something more than just a paperweight on a desk, the implementers of the policy must trust the policy and have been part of the process to develop that policy. So really quick, I want to talk about how we put the National Biodefense Strategy together. Now, I've been part of two of the processes, the 2018 and the 2022, and I led the 2022 process. We needed a consensus document that I think our package was over 200 pages long that went to the president. We had 24 departments and agencies that needed to agree. And the biggest focus was how do you implement, when we were planning and preparing, how do you implement a national biodefense strategy? Now, of course, we built on decades of previous policy, Bush, Obama, the first Trump. We built on all of those policies because it turns out that while words change and sometimes priorities change, foundationally our strategies remain the same. But we need to make sure we can implement those strategies. And we need to have some consistency because they are very, very expensive to write. And we keep moving the goalposts. So if we go back to the fact that we have strategies that are foundational, we can start running to the same goalpost. Now, part of national biodefense includes food and agriculture and food and agricultural security. And really quick, this is super under-prioritized, super under-resourced, and we take our food and agricultural system for granted. Of course, it's about $1.537 trillion of our GDP, employs more than 22 million Americans, and it is under constant attack, deliberate, not deliberate. We've seen African swine fever in the Western Hemisphere for the first time in 40 years. Sorry, that's about $50 billion if one pig in the US comes down with African swine fever. Obviously, we've seen HPAI, I don't need to explain much more there. Made recent news with all the fusarium smuggling that we've seen in the country for research, which is a fungal pathogen of plants. And if you go back a couple years, we had the unsolicited seeds event where we had over 30,000 packages of seeds delivered to random American citizens, mostly postmarked from China. We are constantly under attack, but we are not resourced to actually stop these events, not fully resourced. And if we're talking politically, while farms are a beautiful backdrop to political ads that everybody likes to use, most of the people that pose with a tractor behind them don't actually resource farm security and agricultural security, because that is trade security, economic security, health security, and national security. We are constantly under attack, but we're not funding it that way. Our national veterinary stockpile, I think last time I checked, is 1/50th the funding as our secure national stockpile. And as my USDA colleagues used to say to HHS, oh, that's cute. You get one species and one kingdom. That must be nice. So to wrap up, let me just say, I was a federal employee. I left the government, not because I wanted to leave the government, but because we were having our second child. And my wife said, you have missed the last 2.5 years of our other child's life, so when this baby pops out, so do you. I worked over 1 year of unpaid hours. I worked 8 hours a day for about 17 hours a day. And it is tiring. And we have tons of federal employees, former and previous, in this room that work tirelessly every day in thankless jobs to ensure that there is nothing on the news that pops up that they're not ready for. And so I just want to thank all of my former colleagues who have worked tirelessly, who nobody even knows their name, who have done everything to make sure this nation and the world is safe. So with that, I'm done. Thanks.
Well, Mr. Stiefel, thank you for an excellent presentation, both of you, for your comments and for sharing your insights with us. In the interest of time, I'm going to limit myself to 2 questions asked simultaneously, dealing with the 2 Ps, preparedness and planning. With regard to preparedness, I think the biggest challenge we continue to face is awareness and prioritization of these challenges we face. We are reasonably good at reacting. I don't think we're very good at all at proactive engagement and proactive planning. What would your recommendations be on what we could do to more effectively raise the level of awareness and the need for proactive efforts? That's question number 1. Question number 2 is, as we consider planning, I think the biggest challenge, whether it's global, federal, or our coordination at the state and local level, is bringing all of the entities together in a meaningful and effective way. That coordination, I think, is almost an impossibility at times, given all of the different contexts and dimensions we have to address. How would you maximize the level of coordination as we look at planning? So let me ask both of you those questions, and Ms. Tremmel, Freeman, I'll start with you.
Yes, thank you very much for those questions, both of which are very germane to the environment that we live and work in local health departments. I think, from a planning perspective, I will take COVID as an example. Our health departments had consistently exercised and planned for a pandemic response many times over the years, together regionally with their states, maybe not as much on the national exercise level, but what we found happened during the pandemic that we weren't prepared for or didn't plan for was the federal government structure in response to the planning ended up dictating how much or how little our plans were actually taken and used. And so one thing I would suggest for the future is that we really start from a holistic approach that includes the ground up, the people that actually have to sit on the ground doing the response in the local health department, but all the partners on the ground. It's not just the health department. But start there to see what they've actually exercised for, what they planned for, how they prepared for this, because all that planning sort of was not used during the pandemic. It started over, different agencies became responsible in different ways, and so we have to use what we prepare and plan for as one suggestion.
Good.
So I'll take both the preparedness and planning. And going to the last panel, I have a bias as well, because I was in the federal government for so long doing preparedness and planning that maybe I have a bias that we do it mildly well. But on the planning side, how do you maximize coordination and planning? The U.S. executive policy mechanism is one of the best in the world. We used to have bilateral relationships with other countries, and the sole purpose, one of the main utilities of that relationship was to bring that country's departments and agencies, ministries, together, because they don't have a mechanism to do so. So within the executive branch, we actually have amazing mechanisms to work together in planning. It is harder for the executive branch to work with the legislative branch, and it is harder for the executive branch to get input from outside sources. So I think, how do we maximize coordination and planning? We need to think of new and novel ways or new and novel mechanisms similar to FACA that will allow us to have more conversations with the public during a policy planning and drafting time. With preparedness, we prepare all of the time. So FBI, CDC, FBI, APHIS, they have a federal criminal and epidemiological joint investigation course that they do all around the country and all around the world if there's an outbreak that seems like it could be nefarious. The government's put together the Biological Incident Annex, the Food and Agriculture Incident Annex, and those are textbooks that they've used to train NIMS and the national preparedness strategies. We have planned and we have prepared all of the time. Sometimes it's our failure of imagination, when you look at the H5 outbreak, we had planned for an agricultural incident that was potentially zoonotic, and we had planned how do we work across the federal government and across agencies and outside of the federal government to stop a quote-unquote One Health emergency. But we had never planned a One Health emergency that the agricultural impact of that disease did not meet the bar for what we would typically do to put out H5N1 in poultry, right? Horrible deaths in animals, things like that. So we didn't imagine this scenario, and therefore we weren't preparing for that scenario. So this is where red teaming, blue teaming comes in all of the time, coming up with that imagination and preparing together with the implementers that are on the ground all of the time, and not just once a year to check a box.
Thank you both. Governor Ridge.
Yes, as I listen to the testimony of the past couple of panels, the thought occurs to me, if you care, that the local communities aren't getting quite the federal support they had traditionally depended upon. Could you care to comment on that for me, please, when it comes to public health emergencies and preparedness?
Yes, so we continue to see sort of this bust and boom funding come through to address emergencies without any real substantive continued investment in building the infrastructure that allows us to be more nimble and to respond all the time to the emergencies that we're facing. 71% of our local health departments actually report getting preparedness funding from federal pass-through, and another 49% from state funds and 40% from local funds. So if you consider that funding scenario, it doesn't portend well for local health departments when our federal government is shrinking its resources, particularly in the preparedness realm, because we know that emergencies don't stop for anybody, and including they don't stop to give us time to gather our resources and our funding and our ability to respond correctly. So we have to be ready at all times, and the funding currently that is supporting our preparedness and response across the country is at great risk right now. I think that we have to plan and prepare and exercise newly based on what we believe our resources will end up being, so that we can begin to identify where we won't be able to meet the needs of communities, and be transparent about that and why that might be the case, and also just understand where those gaps are so that we can line other resources and partners and seek other ways to support those response efforts, because ultimately, as our previous panel said, the goal here, the meta leadership goal should be to save lives, not to prevent a single loss of life.
Historically, how dependent have you been on federal funding to help you achieve these goals in terms of stockpiling, in terms of exercising and the like? Most of that has been historically federal funded, has it not?
It has been, yes, it has been. And I think that's what makes this such a unique moment for us in local public health, because we have had that reliance. It hasn't been a singular reliance either. It's a partnership. It's a public health system, federal, state, and local, everybody contributing in some way. But if you take away a large portion of that support from any one of those areas, you're going to end up with a lapse of an ability to respond somewhere along the way. And that's what we're trying to identify, where and how that would occur.
I want to underscore a word that you used. Historically, it's been a partnership. And I think that's really important for us as we go forward, that the collaboration between the federal government and state and local authorities on these issues is key. It's absolutely critical. So I'm glad you raised that. You use the word partnership. That elevates it to my mind to the role that it's supposed to be, we're supposed to include. With regard to public health, there has been has there not been an incredible reduction in the support of public health, the public health community over the past couple of years?
That's correct. We've seen diminishing support, not just in preparedness and response, but across all the domains of public health and prevention areas. I will say too, you know, I would underscore that it is a partnership, and that's really important, and it's a cooperative partnership. But it is also a system. I want to underscore the fact that public health is a system of care in our country. It's not something we can arbitrarily say, we're not going to do it this year or next year. We'll let the states and locals sort of pick up the efforts there. We have to do a little bit more planning, conscientious planning, when any part of that system draws back, pulls away, can't support the rest of the system. We just have to plan for that inevitability right now when we're seeing such a constriction of federal support and dollars in this area.
Is it fair to say that the policymakers in Washington have, at this juncture, seemed to pass on the ultimate responsibility for funding and leadership to public health to the states?
And locals.
And local, okay, very good, very good. Okay, I appreciate that. Thank you.
Fred Upton.
Well, thank you both. You know, I was, one time I was co-chair of the Auto Caucus in Michigan, and I don't know that I've ever had a Fram oil filter, but I sure remember the slogan, pay me now or pay me later. And
Amen.
When I look at your costs on measles, $4 billion, I look at Michigan, we're one of the impacted states. I saw a report earlier this week, I want to say it was 24 states have had a double-digit decline in school immunizations as we're getting ready for September. I think the average was over 20% in terms of a decline. I look at the public health service folks in my old district, and they were terrific. They were real partners. My district was on the border of Indiana, so I'm right above South Bend, Notre Dame. And I see that they're closing offices because they don't have the funds, and Indiana's not going to provide the, you know, when you look at the federal cutbacks, the states aren't coming to the plate either. They're pretty much past their budget proposals. What's going to happen? What's going to happen when this crisis hits us in 6 weeks? What are the predictions?
We're looking
David,
at
I
each
have
other
a question
like,
for
who
you,
wants
so
that?
you're not answering this. This is for Lori.
I'll start by saying that our local health departments have traditionally been
And you
through.
combine that with the Medicaid cuts that are coming too, so that's, all right, that's the other
Yes, and thank
storm
you,
cloud.
thank you for mentioning that, because that is significant also, because the local health departments are not just on the front lines, like I said, but they're also the safety net of the safety net. They are the last resort for caring for the community when community members have no other access points or other places to go to. And so what is going to happen when you see the compression and shrinkage of support federally, and it's not just in preparedness and response. I think it's important to note that this is a across the board, pretty much, with the exception of a few areas, a shrinkage of support for public health. That services and programs will begin to stop and go away. We won't be able to serve as many people locally as we used to. We worry too with the compression of Medicaid dollars, that the safety net need will grow. People will have less and less access to programs and services through even Medicaid, and will revert to local public health for programs and services as the safety net of the safety net. And that we simply won't be able to serve as many people in the community doing the same things in the same programs. So the end result of that is usually outcome oriented, unfortunately. We'll see people getting sicker. people seeking care more, back to sort of the burden on the health care because we have failed at the prevention side, because we're not investing enough in the prevention.
So that 4 billion is going to grow big time.
Yeah, and important to note, these pockets of immunization across the country that are lower because of the herd immunity has gone down are exactly where the outbreaks are occurring. Let's not, let's not sugarcoat it. Look to see the immunization levels of where these outbreaks are occurring, and you'll see they're lower than normal, and those communities aren't protected, and that's why measles is taking hold in those communities. A lot of them are rural. A lot of them don't have a lot of money to pay for these outbreaks, and so it just strains the entire system.
Yeah, and David, just one quick question. Your number one on your 4 priorities was that for a national biodefense, it's got to be coupled with global. What was your working relationship with the WHO that we're no longer a part of?
Yeah, so we had an amazingly productive relationship with the WHO. With every international organization, there are challenges, right? But there are also benefits. And so working with the WHO from the US, and I'll also include FAO and WOA and all the other organizations that deal with health, that allowed us access to diplomacy, to surveillance information of disease threats, research collaborations. We had so many more benefits that we got with by being a member of and working with the WHO that far outweigh any of the risks that would come with being a member of an international organization. There are many aspects of the COVID response that people question related to WHO and to other political influences from around the world. But at the same time, we did get tangible benefits. We did get tangible partnerships. And when we were able to go into a room and negotiate, we could help shape from the US the narrative and the final text. And by removing ourselves from that international organization, the rest of the world's going to keep moving on. And they're going to keep negotiating. And they're going to keep sharing. And we'll just be on our island by ourselves. So we had a very productive relationship. Once again, there are pros and cons to working with international organizations. But the pros, to me, in my opinion, far outweighed the cons.
Thank you.
Jim Greenwood.
Thank you. Fred Upton asked the question of you, Ms. Tremmel Freeman, so I'm going to just ask one question for David. Based on your extensive experience in the National Biodefense Strategy, you're certainly aware of the fact that 10 years ago in our blueprint, we thought it was a good idea to have the vice president kind of lead things. And the logic of that was you have all of these secretaries, and none of them outrank each other, and so there's no way to centralize there was no centralization of leadership. And so, and it's never happened, obviously, with this slight exception of Vice President Pence, who was not active in the preparation, but only in the response to the extent that he was. So what are your views on that? Because we sometimes still feel like that's a gap that should be filled and has never been filled.
Yeah. We have when I was in the federal service, we debated this over and over and over again on where's the correct place. And I will say that in every round of negotiations, the vice president was brought up. As you know, in 2018, where the National Biodefense Strategy and NSPM 14 landed is it went to the Secretary of HHS, who coordinated all of the other secretaries. But as you just stated, one secretary can't tell another secretary what to do. In 2022, we wanted it in the White House. So in NSM 15, we moved it to the National Security Advisor. And the idea was we might not be able to get the vice president, but the National Security Advisor has the ear of the president at all times, and COVID has demonstrated that biodefense is a national security priority, and the National Security Advisor is the one who coordinates national security relevant issues. So in my personal view, it should be in the White House. I see benefits to it being the vice president, but there are tangible benefits to it being the National Security Advisor as well, including a little bit more limited bandwidth of range of activities that they're responsible for doing, where the vice president's responsible for pretty much everything in the government as the number 2 to the president. it should be in the White House. Of course, Murray and Burr also thought it should, at least a partial role of this should go to a newly established office, the Office of Pandemic Preparedness and Response. That has its own benefits and its own challenges as well. So my personal view, just to be very succinct, is it should be in the White House. The coordinator for biodefense should be in the White House. Depending on the White House, it may be better as the vice president, the director of OPPR, if that moves forward, the national security advisor, the Homeland Security advisor. But it needs to be somebody in the White House who can convene all departments and agencies and have some sort of authority to speak into the president's ear on biodefense issues.
Thank you, Jim. Peggy Hamberg.
Thank you. Well, Jim asked the question that I was going to ask of you, David, but thank you for a very clear and compelling response. Thank you both for your presentations and the discussion that I think has been robust. Let me ask a kind of a related question to you, Lori, if I can call you that, which is, as we know that public health has long been under stress, underappreciated and underfunded, that the public health workforce is probably more stretched and fraught than ever before, and the resources more uncertain and unstable. We've thought a lot over decades now about our system of public health at the local and state level as it relates to the federal, and it's a complex mosaic. Some would say, though, it's also very fragmented. As we think about rebuilding in a time when human and dollar resources are likely to be limited, do you think it's time to really readdress our model for public health services and start to move towards something that would be, quite different but more regional in its focus and its work?
Yeah, interesting. So a couple of things come to mind. First of all, I think, there's already a pretty good effort underway, even in the past 6-8 months, to look at filling capabilities differently than the reliance on the federal government. So you begin to see states coming together. Somebody else mentioned New England, Northeast states, the Pacific states are starting to imagine how to support public health with an eye towards state and local control. And what that might look like in terms of sharing of services, sharing of lots of things, capabilities. So I think, in every moment that's a crisis. It's always an opportunity, as they say. And so I think public health is actually looking at this as an opportunity to look at itself differently. And also because the services and programs are so crucial to communities, they're beginning to be forward thinking about how we need to take a look at the core responsibility of public health locally to protect, serve, and keep its communities safe, down to the basic essential public health services. I use essential public health services not in the term of it's, the model so much as what do we have to provide to communities at its most basic level to be able to maintain the health and security of our communities. And then how can we align with the new administration in terms of their reorganization and thinking around health to make sure that we cover those critical services. So to your point, I think there's a lot of thinking about this and not doing things the same because we simply won't have the resources to do things the same way. We're going to have to think on our feet and figure out how to proactively reimagine our field a little bit differently and how we're going to service our communities. Thank you.
Well, thank you both for your wise counsel this morning, but thank you especially for your service and your leadership. It is so deeply appreciated now, perhaps more than ever. Donna, I'll turn it back to you.
Thank you very much. We're going to break for lunch now. Let me thank both of our panelists for their service and for their outstanding presentation. We'll be back at 1 o'clock to start the panels again. Lunch is outside for everybody else, I think. You may have to share sandwiches. Thank you very much.
This panel is detection and surveillance. We are fortunate to have Dr. Camille Hopkins, who is a Fish and Wildlife Disease Research Coordinator for the Biological Threats and Invasive Species Research Program at the USGS, U.S. Geological Survey. Dr. Erica Pan is the Director and State Public Health Officer for the California Department of Health. She previously served as the California State Epidemiologist. And Dr. Tina Tan is the President of the Infectious Disease Society of America. So with that, we'll start with Dr. Tan. And we just, if we could get someone maybe to shut the doors, just to quiet the noise on the outside. But welcome, and we appreciate your participation today. And as you know, we'll have some questions following each of your testimonies. So, Dr. Tan, thank you for being here. You need to push the little button to get that red light on. There you go.
Thank you so much for the invitation to speak with you today. I'm just going to introduce myself. My name is Dr. Tina Tan. I'm a professor of pediatrics at the Feinberg School of Medicine of Northwestern University. I'm a pediatric infectious disease specialist and medical director of the International Patient and Destination Services Program at Ann and Robert H. Lurie Children's Hospital of Chicago. I'm editor-in-chief of the American Academy of Pediatrics Red Book Atlas, and as you said, I'm president of the Infectious Disease Society of America. Now, IDSA is composed of more than 13,000 physicians, scientists, public health practitioners, and other clinicians that specialize in every single area of infectious diseases. And in addition to patient care, we also provide preventative care, we do cutting-edge research, and we provide education to individuals at all different levels. And our members have been on the front lines of COVID-19, avian influenza, RSV, Mpox, antimicrobial resistance, and are really critical to the biodefense capabilities of the United States. Now, the pandemics and the infectious disease outbreaks that our members have helped and continue to help fight have really illustrated the need for supporting federal biodefense and biosecurity infrastructure. COVID-19 really showed the importance for robust funding of diagnostics and for the importance of surveillance for infectious diseases, with the capacity to scale all of these systems up for all emerging threats. And we saw multiple essential surveillance programs and systems put into place because of COVID-19. And this includes the CDC's wastewater surveillance program, which has not only been used for COVID-19 surveillance, but has also been used for RSV surveillance, avian influenza surveillance, and Mpox, and the traveler-based genomic surveillance program that's also administered by the CDC. Now, the recent avian influenza outbreak also taught us crucial lessons, including the essential need for a One Health approach to surveillance. So it's not just human surveillance, it's animal surveillance, and it's surveillance in the agricultural realm. And basically, it's also important to have strong communication channels between private and public health partners. Additionally, we know that antimicrobial resistance remains a major and ongoing biosecurity threat. And this really necessitates critical diagnostic tools, not only for surveillance, but also to guide the appropriate use of antibiotics in every single setting. So we're talking about human health care, animal health care, and agriculture, because we have to do every single one of those settings to prevent the development of antimicrobial resistance. And these threats highlight some of the core biosecurity requirements that I would like to flag for this commission today. The first of these is the healthcare workforce. Federal biosecurity in the U.S. is directly proportional to the healthcare workforce, specifically adult and pediatric infectious disease physicians who are on the front lines of patient care, but also for hospital preparedness and response efforts. And trained professionals are also needed to staff laboratories that are responsible for testing diagnostic samples and helping with the surveillance of infectious disease threats. Second is sustained, robust funding is needed to really ensure federal surveillance programs can function and agencies are able to stand up a diagnostic response to emerging threats. And identification of novel diseases is really dependent on strong systems at the federal. The capacity for surveillance includes not only wastewater surveillance, but also syndromic surveillance. And this must exist at all levels. So we're talking about the local level, the state level, and the federal level, which all have to have well-functioning, modernized surveillance systems that are stood up by agencies like the CDC. But state and local communities really need parallel surveillance systems supported by the federal government to provide a complete picture of outbreaks. And we know right now that our surveillance system is faltering because we continue to have measles and pertussis outbreaks all across the United States. And that is a major issue because we do not know the burden of these two diseases and other diseases because surveillance systems are faltering. And finally, we need continuous strong coordination across both the public and private sectors, including human health, animal health, and agriculture. This One Health issue is major. And basically, this will incorporate healthcare personnel, especially in infectious diseases, in the case of a biosecurity threat. And these communication streams should be well established and tested for functionality before we have an incident occur. And consistently engage on everyday threats to ensure readiness. However, we know that there are major gaps that remain in federal preparedness. The U.S. lacks the healthcare workforce, especially and specifically the infectious diseases workforce that is needed to respond to all seasonal and emerging threats. ID physicians are really critical not only in patient care, but also in developing novel diagnostics and conducting and guiding surveillance efforts. And we urge support for novel programs such as the Biopreparedness Workforce Pilot Program to really help recruit and retain infectious disease physicians and public health professionals. And I would also note that the recent funding and staffing cuts across multiple federal agencies has significantly hampered our readiness. Cuts to ID research at the NIH is going to limit our ability to understand novel threats and develop new diagnostics in public health emergencies. And the cuts to the CDC have seriously impacted surveillance across the agency, as well as the local and state public health departments are losing funding that previously supported surveillance efforts. And we really urge strong support for the biosecurity work that these agencies conduct and the funding that's needed to ensure their success. So in closing, I strongly, respectfully urge the Commission to find solutions to address these gaps and to strengthen the country's core biosecurity capabilities so that we are prepared to respond to all biologic threats. Because I can tell you that with the ongoing measles and pertussis outbreaks that are occurring all across the U.S. and the reemergence of COVID infections occurring. I just came off clinical service, and there was a 13-month-old who basically got COVID infection from her siblings and basically was hospitalized with severe respiratory issues. So we have very safe and effective vaccines against all these agents, and we need to use them in order to provide protection for the American public. And again, thank you so much for your time and for your commitment to these really important issues. I'm happy to be a resource and connect you to my colleagues at IDSA as we continue to work very hard on these issues. And I'm happy to answer any questions that the Commission might have. Thank you so much.
Well, thank you. And I didn't properly identify Patricia Bright, who is a former senior science advisor from One Health Global Health Security at USGC. Welcome, and anxious to hear your testimony today, too. You got to hit that button.
Thank you. Yes, so my name is Dr. Patty Bright. I am a veterinarian with I'm board certified in veterinary preventive medicine. I did work at the Department of the Interior for 18 years, focusing primarily on global health security and One Health. So we define One Health, and I see Billy Karish is here, so many of you have probably heard this definition of One Health before, but we define One Health as being kind of that interdependency between human health, animal health, and the environment. For those of us who work on the kind of environment-wildlife side, we jokingly refer to it often as two-thirds health, because our component of it often gets overlooked. So, I really, first of all, I just want to thank you for, bringing us to the table today. This is such an important issue for us, and we really appreciate being here. From the biodefense perspective, I think in order for biodefense to be effective, it really does need to be a One Health framework. We need to have wildlife disease detection and response must be fully integrated into the work that's being done. For those of you who are not familiar with the term zoonotic disease, those are the types of diseases and infections that can transmit between people and animals in the environment. And we know that every year, globally, there are billions of cases of zoonotic diseases, and millions of people die from them. Again, because Billy is here, you've probably heard some of these statistics before, but 60% of the emerging infectious diseases that are reported globally are zoonoses. So 60% of the diseases. That's a pretty high number. Over the past 30 years, there have been 30 new human pathogens. Of those, 75% first originated in animals. One of the problems we have with the occurrence of zoonotic disease is that it tends to be unpredictable, right? Because it does occur first in animals. It's often caused by novel viruses, and we often only detect it once outbreaks occur. So it is really important that we are getting information on wildlife disease, but the problem is it can often be very challenging to access that information. When we look at the National Biosurveillance System for human health and even for agricultural health, it can be fairly well established, right? We have good channels among CDC, USDA, the states, the local agencies. So a lot of good information is shared. Unfortunately, when it comes to wildlife, we often overlook that critical data that is from wildlife and the environment. While national biosurveillance infrastructure, as I said, has been well established in others, we don't have that same level of integration with wildlife disease. So the question is why? There's a couple of reasons. First of all, some of it is about regulatory authority. Different species are regulated under different authorities by either feds, the states, or the local agencies, or tribal or indigenous groups. So that can be a little bit challenging. But some of the other issues that we that we have the ability to address more directly, one of them being resources. Okay, so there are not consistent resources for these types of issues. And I'll give you an example. When West Nile virus was first introduced into the United States, we saw a surge of funding, right? There was a lot of activity, there was a lot of network building, and then people kind of lost interest. And the funding and the resources and the networks kind of tailed off, right? And then a couple years, but the disease was still here, right? We're still spending millions of dollars every year. We're still having people die from this disease. A couple years later, highly pathogenic avian influenza raises its ugly head. And all of a sudden, we're kind of doing this again, right? We're trying to scramble to get back up to where we need to be with funding and resources. And of course, because we're dealing with appropriated funds, there's always going to be a bit of a delay in getting the funds that you need. So it is difficult to kind of get on the ground and do what you need to do immediately. So funding is definitely a big issue. I know, as Dr. Tan mentioned, the potential cuts that are out there, particularly for the Department of Interior and, my former employee, the U.S. Geological Survey, could potentially significantly impact the work that's being done on wildlife disease and may even eliminate it, because right now that funding also includes funding for our National Wildlife Health Center, where a lot of this work is done. What else? Let's see. We also lack standards. So when it comes to things like avian influenza, for example, we spend a lot of time and money on the agricultural side trying to develop good tests and diagnostic methods. When high-path avian influenza hit and we were concerned about it arriving here via migratory birds, we realized that we didn't have good diagnostic tests. We reached out, we were trying to use the poultry tests, but surprisingly, they didn't work in some of the species that we were most concerned about. So again, funding to have kind of research looking at these things in advance is important. We also need federal leadership. I'm proud to say that Department of Interior has been a leader in this area through Fish and Wildlife Service, USGS, Park Service, Invasive Species Council, and their Office on Emergency Management. They are really good about promoting collaboration, sharing wildlife health information to provide situational awareness, and making timely information available for wildlife disease threats. I'm happy to talk more about where there are some opportunities to improve this, one of them being more cooperation in a One Health framework, another being adding wildlife expertise to incident command systems as a normal part of the incident command system. But I just want to finish by saying, active biosurveillance for wildlife disease and environmental events is key to early warning and detection and overall situation awareness. Having consistent interagency networks that cooperate across all three components, right? Human health, animal health, and environment and wildlife, really will enable better communication, coordination, decision-making, and data-driven responses. So thank you very much for your time. Again, I'm more than happy to provide future resources or information as needed. Thank you.
Terrific. Thank you. Dr. Pan.
Great. Good afternoon, commissioners. It is such an honor to be here. As mentioned, my name is Dr. Erica Pan. I'm California's State Public Health Officer and Director of Public Health. Like Dr. Tan, I'm a pediatric infectious disease specialist as well, and I started my career in local public health 22 years ago, focusing on infectious disease emergencies. And I thank you all and your staff for this opportunity to share my perspective on what we need to keep our nation safe from biological threats. You will hear many themes echoed from prior speakers and hopefully some new points to consider. There are three key areas that I want to emphasize as core to surveillance and biodetection: data, lab, and people. Number one, data systems. Public health agencies must continue our progress to modernize our data systems at all levels. We need secure systems that can efficiently collect, store, and report data, be interoperable with electronic healthcare systems, and allow for flexibility to add investigation details, prioritize our interventions like medicines and vaccines, track that distribution, and share that information promptly and transparently with decision makers and the public, all with appropriate privacy and governance. Number two, lab capacity. We need to maintain and continue development of the network of unique public health and food safety labs to test people, animals, and food products. Sorry, I just lost my place here. And when relevant, environmental samples, like water. We must also be able to rapidly disseminate and validate test methods to scale up a response. Number three, people. We must have the right people in our workforce to maintain readiness and respond effectively. This means having trained and experienced staff to test, investigate, diagnose, provide technical assistance, maintain these data and lab systems, analyze that data to track the scope, the scale, and the direction of situations, inform our resource prioritization, engage our communities to keep them informed and build trust, and communicate with leaders, and coordinate all of this across local, state, regional, and federal systems and partners to enable a timely response to protect Americans. Where are our knowledge and capability gaps? We need nationally available tools to collect and track this data at all levels, as I just described, with coordinated health information exchange across our very decentralized healthcare systems. For example, there are multiple different systems we use currently to receive data from our healthcare partners nationally with varying participation. These 3 different national systems, one focuses on healthcare information from emergency rooms for syndromic surveillance. A different one looks at our hospitalized healthcare infections and largely how we tracked COVID during the pandemic. And another one looks at electronic case reporting. Then there are other data systems of variable capacity across states and locals existing for other core public health functions like case reporting, case contact and outbreak investigation and management, hospital bed capacity, and laboratory information management. Our lab system needs to be able to embrace disease-agnostic metagenomic testing for emerging unknown diseases instead of relying on testing for specific diseases. We also need ongoing resources to continue whole genome sequencing, which helps us not only identify pathogens, but sheds light on their source and their evolution. As we learned from avian flu and all prior pandemics, a One Health approach where we collaborate across the spectrum of human, animal, and environmental health is essential. Wastewater testing has been a promising new method that complements other health monitoring techniques and has provided data we learned during avian flu from human, animal, and environmental sources, helps us monitor trends. But we need more time and resources to better understand and use this data. I have 3 recommendations requiring federal leadership and resources. Number 1, invest in a nationally coordinated health information data infrastructure. Our health information technology progress is at risk. We need to keep enhancing our systems to detect trends, investigate issues, and protect privacy. Ongoing investment in modern, secure technology and data governance is critical for an effective public health response. Number 2, modernize our public health lab response network. We need a lab infrastructure that can test broadly for emerging diseases and scale up rapid testing quickly across the spectrum. If we don't even know we have an emerging disease, where it is, how many, how fast it's spreading, we can't even begin to work to contain and mitigate its impact. Early detection is our unique governmental role, distinct from patient and disease-specific healthcare testing. Number 3, maintain investments in our people, in our public health and healthcare workforce. We must have boots on the ground, serving our communities directly, and the ability to coordinate and provide additional resources and expertise at local, state, and federal levels across all of these areas I've described: investigation, data management, lab testing, coordination, and communication. Proposed cutbacks to emergency preparedness grants for state and local health departments and hospitals will impair our readiness. Reducing public health and scientific funding endangers our public safety and undermines progress made during the pandemic. Cutting research and development for medical countermeasures and reducing participation in global health initiatives like the World Health Organization are detrimental steps in the wrong direction. If the COVID-19 pandemic and recent avian flu outbreak have taught us anything, it's that we need cross-sectoral and multi-layered collaboration. We must move away from the cycle of panic and neglect and maintain investment in the people and systems that keep our communities healthy. Thank you so much again for this opportunity to share what it takes to keep our nation safe. I'll be happy to answer questions.
Well, thank you, all 3, Dr. Pan. I'd be interested to know, I know you were very involved with California's response as related to avian flu last year, particularly its interaction with animals and humans. I wonder if you could just talk a little bit about your experience in terms of what you did successfully to counter what would have been clearly a real disaster.
Sure, thank you so much for asking that question. And I'd love to walk you through a little bit of how we were responding. When we first learned about the dairy cattle in Texas, and also knowing that that was such a novel situation, we started organizing early on with our emergency coordination and response, including our One Health teams. We started meeting and partnering with our Department of Agriculture and Fish and Wildlife. And then we also began outreach and preparations with our local health departments, our public health labs, and our healthcare networks to ensure everyone could start to be ready to stand up testing for human cases. Once we had infected cows in California, which was a few months later, we increased our level of activation and worked with local health departments and agricultural areas to help them monitor and educate their dairy owners, their workers, and healthcare providers on personal protective equipment and testing to prepare for human cases. We not only gave them that education, but we distributed over 5 million pieces of personal protective equipment for those agricultural workers. Once you had infected dairy workers, then our public health departments worked to provide timely treatment and also interview those people and learn who do they live with, who do they go to work with, and then offer preventive medicines and monitor those individuals for symptoms and assure timely testing. When we were doing that, we were able to use one of the systems we stood up during the pandemic to closely monitor and let the dairy owners actually monitor their workers for symptoms and made it really easy for them with technology. And then we started hearing more and more about the feline deaths, and a local public health partner started testing retail milk and found positive H5N1 in our retail raw milk. And so then we increased our outreach to veterinarian communities as well and started investigating more of the feline deaths. We needed all of those data systems I just described, again, to monitor those exposed workers, make it easy, track our positive cases in those investigations and their contacts, and ensure that timely access to treatment. We also saw that wastewater surveillance was such an interesting tool. We thought, we developed this for human disease, but we started seeing areas where there were dairy processing plants or even milk dumping, and we saw it really tracked the overall burden of virus circulating in our state. And all of that, of course, needs to be tracked again at all different levels. We worked really closely with our local health departments across the state and with our federal partners, and all of that had to be, every single case had to be reported to the World Health Organization as well, as this was a novel disease. We're still learning in that process, though, what kinds of specimens are the best ones to get the best yield and the easiest to collect with the most compliance. What kinds of illness are we seeing in this disease, even though we'd seen such high mortality in other countries? And we were continuing to learn and still are learning, how is this virus spreading so quickly across animals despite really aggressive containment efforts in the agricultural community? We had a lot to build on from the poultry outbreaks before that, but it was really different with the cattle. So again, that's a really good illustration of why we need to maintain all of these capabilities and this cross-sector collaboration.
Well, thank you. Jim Greenwood.
Thank you. And thank you each for the service that you provide our country and for being here today. Each of you referenced the federal cuts in spending and the impacts that it's going to have on the functions and the operations that enable us to do the surveillance that we need to do. I wonder if you could each give us some, to bring it down to the human level, the patient level, some examples of what you fear could be some of the worst outcomes in terms of human health, lives lost as a result of some of these cuts and the kinds of things that keep you awake at night.
So basically, the thing that is that gets me really worried is that with the drop in vaccination coverage rates and the cuts in different programs that provide vaccine access to individuals that do not have the financial resources to basically get vaccines, we're basically going to have more individuals come down with these very serious vaccine preventable diseases. And the problem is that as things continue to get cut, we're not going to be able to monitor and put out surveillance so that we get a good idea of what the extent of the disease is. And we're already seeing that now.
Which means you can't get a handle on how to prevent the spread.
Correct. We don't know how fast it's spreading. And the measles is a perfect example, because initially it seemed to be just in Texas and New Mexico, and now it's in close to 40 states around the U.S. And a lot of that has to do with the fact that, there are now large communities of unvaccinated individuals that then travel from state to state to state, and they basically expose individuals to the measles. And Canada is also having that problem. Ontario is having a major measles outbreak right now in the unvaccinated population. And the same thing, they are worried about spread, not only to Canada, but also here in the States.
And to put a point on it, that's going to mean that because of these cuts, children and adults are going to die who wouldn't have otherwise.
Absolutely. And the thing is that, God forbid, we have another pandemic of some sort or a novel infection. We're just going to be overwhelm the system, and we're not going to be able to provide the best care possible in diagnostics and other things that we should be able to do because of all the cuts.
Thank you. Dr. Bright.
Well, and I think when we're dealing with any disease outbreak, but particularly something like a potential pandemic, prevention is key. We know that, right? I mean, whether it's through vaccines, whether it's through risk assessments and knowing where we need to put our priorities, where we need to be doing detection. And wildlife, again, when we're talking about zoonotic disease, wildlife is key, right? Think back to West Nile virus. How did we first detect that? Dead crows. At the time, I was working in a wildlife clinic in Virginia, and we were seeing birds that were coming in with specific symptoms. My colleagues out west were seeing animals come in with very different symptoms. And so the virus was evolving. We were seeing different things, and it was through wildlife that we were able to know where that disease was moving, where we needed to be placing our resources. When it comes to highly pathogenic avian influenza, there is an interagency migratory bird HPAI steering committee that is, right now it is being chaired by the Fish and Wildlife Service, but it is Department of Interior, CDC, USDA, states. They work very closely, and again, when we were looking at HPAI, we knew in the poultry, when we had the poultry outbreaks, it was being moved around by migratory birds. That's what was happening. If we didn't have that information and we didn't know where those birds were going, we weren't going to be able to stop that disease. So this information is critical. These risk assessments are really going to be key to helping us prevent further deaths, to save money in the long run. The kind of cuts that we're looking at right now, if we are losing that diagnostic capability, if we are losing those surveillance and detection, one of the things that USGS is currently working on developing with the Department of Energy is something called the Wildlife Disease Database. And so this is going to be a platform. It's actually going to, the information is going to be put in. It's a One Health type platform that's going to be put in. It's going to utilize AI-driven analysis for situational awareness, for anomaly detection, for predictive analysis. And then it's going to provide that information back to decision makers so they can do risk assessment. So again, so they know where to put the priority. Those cuts have the potential to stop the development of this project in particular, but other projects as well. Again, our National Wildlife Health Center has been key, particularly in avian influenza, in helping to detect and work very closely with USDA and CDC on many of these risk assessments, on developing new diagnostic capabilities so that we can look at these diseases in animals and know whether it's there. So yeah, these risks can have pretty significant cuts. I mean, these cuts can have pretty significant risks. Sorry.
Yeah, I mean, the diagnostic part of that too, because these organisms continue to evolve. And if we can't look at the organism and see what changes are being made, you may get the organism to a point where it starts out in animals and then rapidly spreads to humans. And that's going to be a major issue.
Causing death.
Causing lots of death, yeah.
Dr. Pan?
Sure, just to build on my colleagues' examples, I remember actually in the 2015 measles outbreak when we had large, after the amusement park exposures, I was at the local level, and for every measles case, there's around 100 contacts because it is so infectious. We were using manual sort of spreadsheets and other things, and we lost visibility in the ease to prioritize. We want to be able to reach the pregnant women, the infants who've been exposed, and get them immunoglobulin or vaccine as soon as possible. If we don't have the tools that we have now that we built post-pandemic, we're going to go back to pen and paper, Excel spreadsheets, and not be able to prioritize for examples like that. I'd say just, again, lost visibility. If we lose the lab detection, my partners have already outlined that. And then bringing it back to our farm workers, the people that feed us, they already have very poor healthcare access and loss of trust, but we've been able to, with resources, bring services to the community where they are. You all saw that during the pandemic as well, and we certainly did that during avian flu. Although similarly, because we have such a sort of disease-specific categorical one-time use, a lot of the funding and resources to really help that were actually much later into the response than we could have done sooner. And we even had challenges with, resources that are already in the field and mobile community testing, vaccines, education and outreach, that if it's disease-specific funding, it's really constrained to that, even though these are all very similar resources and principles. And again, bringing services to people where they are, we're going to see a lot less people tested, and not have that detection, and then the disease will spread.
And people will die. Thank you.
Dr. Hamberg.
Thank you very much. I think a very enlightening and important set of presentations and discussion. I'm just wondering how you've all made the case for why integrated systems are so important and valuable, but how much progress are we making towards really having those kinds of systems? I remember back when I was in leadership roles in local and federal public health, we talked a lot about it, but we hadn't made the progress in terms of having data systems in different sectors, different agencies of government, and across the healthcare system and the public health systems that could actually communicate shared standards for data collection and sharing, and also, of course, integration of new tools that could enable us now to do a better job. So I'm just wondering, are we making continued progress, or is that one of the things that has been sort of arrested by the current state of public health and now ongoing funding cuts? And are there things that we could recommend that would help to advance that integration and help to encourage the investments that are needed at the different levels and different components of the system?
Sure, I'm happy to at least take a first response to that. I think we have, especially with resources post-pandemic, made a lot of progress. The systems I mentioned, many people weren't using any of them, and now we have more ability to do that. So we need to sort of get off pen and paper and Excel spreadsheets as step one, and then move towards integration. But there is a lot of progress that's been made, and I would say it is definitely at threat in the proposed appropriations budgets. But I think some really specific things are there have been data modernization initiatives at the CDC level, and line items in our appropriations, and if we can maintain or even increase that, and again, have long-term investments in that, I think that will make a huge difference. I think many of the electronic healthcare partners are really coming to the table as well to work with public health systems, but we need resources, people, to be continued investments in that.
Yeah, that's especially important with antimicrobial resistance, because if, you try to control the appropriate antibiotic use and say humans and in animals, but then in the environment and agriculture, they continue to use it, you basically continue to fuel that. And that's a major issue. And the funding cuts actually are going to have a major impact on the ability of hospitals to set up surveillance systems and monitoring systems on antibiotic use and the development of antibiotic resistance among the organisms that are isolated. And that's going to be a major issue, because once you lose the ability to treat somebody with an antibiotic, there are now organisms where there may be only one antibiotic that organism remains susceptible to, and if you lose that, there is nothing you can treat that person with.
So I'll add to that. I do believe that we have made a lot of progress. I was around in 2007 when we first started working on highly pathogenic avian influenza, when we were concerned about it coming over in migratory birds and being introduced into North America. And the agencies were each very much working in their silos. And I'm proud to say that, we came together. This steering committee that I mentioned earlier was created. There was a lot of trust built. There's a lot of information that is now shared between, like I said, CDC, USDA, DOI, as well as state agencies. And I think that's incredibly important. We also have now what's called a One Health Coordinating Unit, a national, and we just developed a national One Health plan. And again, that is across, there's at least 24 agencies or more that are involved in that process. But, as we've been undergoing these cuts over the last couple of months, or proposed cuts, what I hear when I go to those meetings is that, more and more people are talking about what activities they can no longer do.
Right.
And the activities that are being done and being brought to the table, they are critical. They are critical for prevention. They are critical for things like antimicrobial resistance. Without that information, we are going to go back to 2007 or beyond. And so I really hope that we can continue to move forward without the resources. And again, I think having consistent resources is important. This idea that we surge things when there is disease means that every time something happens, we have to rebuild that framework. We have to rebuild that strategy. And that's just not effective, and that is not the way to get ahead of these diseases. As I mentioned earlier, with zoonotic diseases, we often don't detect them until after the outbreak is already in place. So it's really important that we have those preventive steps there.
Susan, last question.
Building on that, Dr. Bright, a little bit, what are some of the wildlife diseases you are most worried about right now?
Well, obviously HPAI is a big one because of the human opportunities there. With all of the coronaviruses, there's an opportunity there. They are continuously changing and modifying, and so we know that there are opportunities there for other things. One of the other things we're very concerned about is, we do see a lot of wildlife trafficking and the illegal importation of wildlife, as well as legal importation. You think about these animals and many of them have been exposed to coronaviruses or carry viruses that are, a normal part of their biome. They are now being mixed together when they're being, during this process, they're being mixed together with animals from other continents. They're highly stressed. It's the perfect vessel for creating new viruses. So, we're looking at things like avian influenza and hantavirus and MERS, but we don't know what the next big issue is going to be. That's why what we're talking about today is so important.
And some animals are actually mixing bowls for these viruses. So the swine are actually considered to be mixing bowls for influenza viruses. And so the highly pathogenic avian influenza, in addition to other influenzas, basically they can spread it not only to other animals but to humans.
And add that to the fact that we have a very large feral swine population here in the United States, so that makes it all the more challenging. Yeah.
And to quickly punctuate that, we know that we're basically one mutation away with the HPAI right now. And again, we've seen it aggressively spread across different species, and we can see that because of this technology that we have. But if we don't continue those investments, we're going to lose sight of that. And to also, the other punctuation is that the 2009 H1N1 pandemic was also a mix of avian, swine, and human flu. So the 2009 H1N1 flu pandemic was also a mixed virus from avian, swine, and flu, a human.
To conclude, I have a very scary thought. I represented a particular county in my district that had 10 times more hogs than people. And it's likely that they're going to lose the only hospital because of the Medicaid cuts in the entire county. So it's a very serious situation. Appreciate your testimony. Thank you. We look forward to working with you in the future, that is for sure.
No, thank you so much.
Thank you.
Thank you. We're starting with our fifth panel, focused on response, recovery, and mitigation. Thank you all for coming and being a part of this panel today, focused on state and local government response, as well as CDC response. And I'm going to just very quickly introduce our panel. Clint Osborn, to my left, is the director of the District of Columbia Homeland Security and Emergency Management Agency. So thanks. You are participating on behalf of the National Emergency Management Association. I think I spoke to them when I was in Congress once, which represents state emergency managers. So very important. Next to him is Dr. Ali Khan, Dean of the College of Public Health at the University of Nebraska Medical Center. University of Nebraska Medical Center has often been a focal education institution focused on biodefense, and so want to thank you for your leadership there. Dr. Alex Hamberg is the Pennsylvania State Veterinary and Vice President, you're the State Veterinarian, and the Vice President of the National Assembly of State Animal Health Officials. Assume you know Dr. Bright, who was just here. And then Dr. Richard Hatchett is here with us as well, is the Chief Executive Officer of the Coalition for Epidemic Preparedness Innovations, known as CEPI. So want to thank you all, and so please, Mr. Osborn, if you'd like to start with any opening remarks you might have.
first. I was planning to go last.
Oh, were you?
No, it's okay. I'll be brief. I want to thank you to the chairs and to the commissioners for the invitation to participate in this important discussion, and it is an important discussion. We've heard from a number of true experts in the field, so I'll try not to embarrass myself or the association that I represent today, which is the National Emergency Management Association, and that's the association of the state directors of or the directors of the states and territorial and the District of Columbia emergency management agencies. And in this role, we play part of the network of agencies and organizations that support our emergency management programs, support our public health programs, when our public health programs have to go from prevention and protection and risk reduction into a response and recovery mode. I also represent the perspectives and point of view of local emergency managers. The District of Columbia is unique in that we fulfill both the state roles and the local emergency management roles. And through the Big Cities Emergency Managers and the National Homeland Security Association, we bring a lot of different perspectives that marry up to the state and marry up to a lot of the conversation that's been happening today with FEMA. Briefly, for those who are not familiar, emergency management is the function of public administration that coordinates the whole of government response to emergencies and disasters. Lenny talked about meta leadership, and for many of us in the emergency management space, that's where we sit. We sit at that space where, as the retired general said, we don't command and control, we coordinate, collaborate, and in many ways we support. And before an emergency occurs, you'll find your local emergency manager or your state emergency manager focused on reducing disaster risk through policy, infrastructure improvements, and other actions that will either reduce how vulnerable we are to a threat or limit the impacts if that threat does occur. And broadly, this is the mitigation process that I think our panel is here to chat about. It dovetails with the preparedness and planning that we heard about this morning, but it also prepares us and readies us for the inevitable, which is that we can't prevent all threats and hazards. The committee's talked about that today. How do you call it a win when people have died? And I don't necessarily view it as a win-loss game situation, but we know that we cannot prevent all threats and hazards, and that means that we have to be prepared and resilient in the face of at least initial overwhelming odds as we observe and orient the situation that we're in, and then make decisions that will reduce the ongoing consequences. So as those things slip through our defensive systems, they force us to respond. And during a response, your emergency manager, during any emergency, but including a biological threat, will focus on 5 things. First, we have to understand the threat, the hazard that we face. What are the impacts? With public health and medical issues, this relies on close collaboration and coordination with the health leads that we have, whether that's veterinary, whether that's human health, whether that's environmental health. And we have to understand the problem and ensure that our senior and executive leaders have clear understanding of the potential impacts. Understanding those impacts allows us to activate and expand the organizational systems across our government agencies, our partners in our community, to address the emergency. When COVID-19 hit in the District of Columbia, our health department was the lead technical specialist, the lead advisory, the lead for epidemiology. But when it came time to reduce and eliminate the consequences of COVID-19 in our community, it was a whole of government approach that we coordinated, facilitated as emergency managers. The last thing you want me doing is predicting disease curves, right? But the first thing you want me doing is making sure that all the people are around the table that need to be around the table to understand the problem and address it. The third thing we do, once we've understood and modeled, if we have to, the consequences, is we start to understand that threat, in this case of transmission, the medical implications, and we evaluate the impacts to government services, private services, and the supportive safety nets to the community. As we saw during COVID-19, it wasn't just an issue of would our health and medical system hold up, but could our human services, our non-congregate sheltering, could we alter and modify the way we did that to reduce the spread of disease in our congregate shelters and things like that? And we had to look across the entire sweep of government to make sure that our government, our nonprofit sector, everybody could decompress and continue with their critical missions that support the community every day, even while we managed the COVID emergency. Fourth, we set objectives and we relay intent that guides our operations and our response operations. With COVID early on, it was stop or slow the spread of COVID-19 in our community. That was objective number one at all times. And objective number two was maintain continuity of government. And the fact that they're 1 and 2 is important because they're part and parcel of the same thing. And we in the district, under Mayor Bowser's leadership, we poured all of our focus into it, all of our resources, all of that went through the coordination process that we established. And finally, and we've talked about it a little bit in some of the panels today, our ability to bring together not just the operators, but the communicators. We do work, but our community does more work during any incident. And our ability to produce good, vetted, trustworthy information for our community allows our community to take the protective measures that really help us achieve our objectives. We can't stop and slow the spread of COVID-19 in our community if our community doesn't understand how to properly socially distance, how to properly hand wash, how to properly wear masks, things like that. I'll defer the rest of my time. I'm really excited to be here and answer questions, and I look forward to the questions that the panel has. And Dr. George, go Tar Heels.
Dr. Khan.
Thank you, Representative Brooks, and thank you for the Commission for the opportunity to speak with you today. More importantly, thank you for how you've kept preparedness and biodefense top of mind for policymakers for so many years. It's, as we've discussed during the course of today, it waxes and wanes, so it's nice to have a group that always keeps it top of mind, because we're always at risk of the next pandemic. So as you heard, I'm Dean of the College of Public Health. I also serve on the steering committee for WHO's Global Outbreak Alert and Response Network. Prior to my current role, I spent 25 years at CDC as an Assistant Surgeon General and ran the Office of Public Health Preparedness and Response. So my remarks today are sort of a fusion of academia and federal service and local practice, essentially. I was asked to do 3 things. I was asked to talk about mitigation and recovery. I was asked to give my current perspective on preparedness in the United States, and I was asked to provide 3 policy suggestions moving forward. As far as discussing mitigation and recovery, the simplest approach is to take FEMA's framework of prevention, protection, mitigation, response, or recovery, or the abridged public health framework, which is preparedness, response, and recovery. Now, most people review these as discrete or potentially as a cycle, and probably the best way to review these is mitigation, protection, prevention, and mitigation occur concurrently in communities at all times. And then preparing for response and recovery happens as part of that work that's going on in your community all the time. But then once you are in a response and recovery happen immediately at the same exact time. Obviously, the majority of your initial work is the response, but the moment you're responding to something. So there's a recovery for the people impacted in the community or the infrastructure impacted in the community. So recovery started essentially the second your response started, and then as you move through the response, obviously the recovery effort sort of blossoms, and the response efforts slow down. Now, unfortunately, over years, what we've seen is recovery does never get the attention it needs, especially the long arm of recovery when you think about mental health, not just for the community, but for the responders. Now, regarding the current state of mitigation, response, and recovery in the United States, I guess the best way to frame this is it's a paradox, and I think we heard this from the first couple of speakers today. So there's no doubt we are better prepared to respond than we were before the COVID pandemic or H5N1 or any of the other outbreaks that we've handled over the last couple of decades. I think everybody understands the value of real-world data analysis and dissemination at whether it's a local, state, tribal, level and federal level. Thanks to Operation Warp Speed, we achieved the holy grail of potential future wide-scale vaccine availability in potentially 3 to 6 months, never conceivable before that. And we now have the RNA scattered, and I'll use RNA, throughout our communities about what leadership looks like within our communities at multiple levels for the next response. The paradox, however, is that in the current policy environment, mitigation efforts have actually been degraded. And it stems from a number of factors. You've heard them today. Disinformation undermining public trust in public health practitioners and in government. I believe as of March of last year, 24 states have passed laws restricting public health within their states. The federal government just clawed back $11.4 billion in funds that were allocated for preparedness response and broader public health issues because the funds were no longer necessary. I think we've heard earlier that those funds were very much necessary and remain necessary in our communities. The EPA has abandoned any efforts around air pollution mitigation at this point, which obviously impacts health and public health. And then finally, the U.S. withdrawal from the WHO, which we helped found, where the United States previously played a leadership role in quickly identifying what was going on and responding to keep it off the American shores. So, and I've already talked about recovery. All I have to say is FEMA trailers, and people go, oh yeah, FEMA trailers years later, right? We don't get recovery right yet, never have. That would be something nice to get better in the future. Now, regardless of the policy environment, so if extreme weather events are due to climate change or due to weather manipulation, if pandemics are due to natural spillover from animals or due to lab leak, doesn't matter what your philosophy is, we are at risk of the next pandemic all the time. And that risk increases for various reasons, both natural and deliberate. At this point, there's a convergence of ideas, so to keep this short, I think people have already spoken about the three things that I was going to, my last comment was, what were the three things I would suggest to bolster the front lines of public health? The first was to maintain a federated, interoperable biosurveillance system using a One Health approach. So that'll be my turnover to my lovely veterinarian here and Dr. Bright. The second is sustained flexible funding for local public health. And the third, I think, which has not been mentioned, is we need to think a little bit better about regional response networks rooted in public, private, academic partnerships. And this may help us address some of these issues around workforce shortage. This already exists when we think about biocontainment centers across the United States and what that network looks like. And there's an opportunity to sort of enhance those networks to help support states and regions for the next pandemic. And I will stop there. Thank you again for the opportunity.
Thank you, Dr. Khan. Dr. Hamberg.
Thank you. I'm Alex Hamberg. Thank you for having me speak before the committee today, and thank you for all the work that you've done through this commission. So I spent most of my career in pathology and virology before I became the state veterinarian for Pennsylvania. Pennsylvania is a very large agricultural state. Not only is it a large agriculture state, it has a very wide diversity of species and production systems and people that all work in that agriculture. It's also very much the crossroads of America when it comes to agriculture. We are the gateway to New England in a lot of respects from an agricultural perspective, and animals from all over the country come through or to Pennsylvania at some point during production cycles. What I'm about to say today, I speak from experience with some of the unique challenges we've had in our state with highly pathogenic avian influenza, and you'll notice that some of the themes from earlier speakers today will come out again with what I'm about to say here. So, it has relevance not only for Pennsylvania, but for the nation at large. I think, first and foremost, we need strong national policy and consistent funding. A few examples of why this is important. For example, it sets not only a base set of resources, but also a framework for response that allows minimal disruption of interstate trade, and it also allows for more smooth transitions from phases and across state lines. It also allows for better preparation when you're getting ready for a response, as well as the mitigation of that response. A real good example of that is our detection dogs at airports. Those are long-term investments. If we're in an environment where funding is uncertain, it's really difficult to plan for how many detection dog teams do we need. And those are, in a lot of ways, our first line of defense from the entry of foreign animal diseases to the United States. They are excellent at finding all kinds of contraband in our luggage and cargo and things of that nature. I think an even more salient and time appropriate example here would be COPEG. COPEG is the cooperation between the Panamanian government and the U.S. government for the production of New World screwworm sterile flies. As we're all aware, New World screwworm, for the last 30 or so years, it's been kept down below southern Panama, below the Darien Gap, and it's been kept there by a barricade of these sterile flies that prevent it from replicating and moving north of that barrier. For years, there's been constant messaging and information from USDA that that facility is underfunded, it's derelict, it can no longer keep up with its mission. And here we are today where that screwworm has now penetrated that barrier at the Darien Gap, and it's made it all the way up through Central America into Mexico. It's now roughly about 300 miles south of our border here. That's a situation where potentially funding that could have been cheaper than the response we're putting out now, and will certainly be cheaper than the expected $4 billion damage it would cause in the short term should it come to America, and it's not that far. Risk is also not proportional to the size of the industry. A lot of the way our preparations and responses are funded is based on the size of the industry. Pennsylvania doesn't work like a Midwestern state. We're very different from South Dakota, for example, but we're still part of agriculture. Times USDA will act somewhat like the Midwest Department of Agriculture, but we need them to be the United States Department of Agriculture. And what I mean by that is if you take a look at a smaller state, I'm going to pick Massachusetts by way of example. They have swine, they have cattle, they have birds. But they're small industries. They tend to be largely disjointed from the greater industries and throughout the country. What also they have is a lot of ports. They've got a major international airport. They've got a major seaport. They've got a huge amount of tourism. That brings people from all over the world, including countries with diseases that we don't want, to Massachusetts. If, for example, African swine fever were to be introduced into pigs in Massachusetts, they would be at high risk because they've got high exposure. However, they don't necessarily have the funding and the resources for the surveillance apparatus of a larger agriculture state, say Pennsylvania or South Dakota. If we do get African swine fever in Massachusetts, it's still in America, and it will have a much bigger impact on the swine industries in places like Minnesota, South Dakota, Iowa, Pennsylvania, North Carolina, even though it's still in Massachusetts. So we are all linked, and in many ways our defenses are only as strong as our weakest link, and the same goes for our response and recoveries. There are bigger threats out there that we cannot forget about. Just within the past 6 months, there have been 2 introductions of foot and mouth disease into Europe. One from a strain found in Turkey into Germany, and then a separate introduction from a strain found in Pakistan into Hungary. To this day, we have no idea how either of them got there. We're currently importing beef from the foot and mouth disease free section of Paraguay. These all increase risk. There's also products coming from all over the world that are coming from foot and mouth disease positive countries and African swine fever positive countries, as well as a variety of other diseases that we certainly wouldn't want here. Additionally, we are importing feed components from all over the world, right? Porcine epidemic diarrhea virus has wreaked havoc on some of our swine farms, especially in the Midwest. That, we're not exactly sure how it got to the U.S., but most likely it came as contamination in feed sacks on feed components imported from China. There's a lot of vulnerabilities here when we export our base component production. And some feed components are heavily bottlenecked. Several years ago there was a factory fire in a factory that produced lysine, which is an essential component for balancing pig rations. That sent ripples throughout the world because that took out a huge portion of the world's supply and sent our swine farmers and nutritionists scrambling to figure out how are we going to keep these pigs fed if we can't give them enough lysine to balance their diet. And I think animal disease, what can we do about it, right? These are a lot of threats. How do we handle it? Animal disease traceability and early detection are keys to stamping it out and getting ahead of things. United Kingdom, a country roughly the size of Pennsylvania and New York combined, back in 2001 had an introduction of foot and mouth disease. They addressed it. It did $19 billion in damage at the cost of 6 million animals depopulated on over 120,000 farms. It got everywhere because they had poor initial detection. They also had poor animal disease traceability. They were hit again in 2007. This time, the second time, it cost about $200 million in damages and depopulated about 2,000 animals and affected fewer than 10 farms. The difference there was they fixed their animal disease traceability and they fixed their surveillance networks. We in America are largely using the same animal disease traceability techniques that failed England in 2001, and we are quickly falling behind our industrialized peer nations in that respect. We've heard earlier today pathogen agnostic testing. It's not just for people. We need it for the veterinary world as well. We have the technology. What we are lacking are the expertise, especially in the agricultural side. That may have been able to get us to high-path AI when we saw sick dairy cows a lot sooner than waiting for someone to notice a bunch of dead cats and make a connection, or a bunch of dead birds and make a connection. We need to build that expertise. We need to get the equipment. Perhaps that would be a good option for some sort of a national resource center that could service the entire country's needs. And we also need to protect our options for surveillance, prevention, and response. There's been a lot of issues that we've heard today, misinformation leading to a mismatch between public opinion and science. And those have the ability to remove options and techniques and methods from our arsenal in both protecting and preventing from these diseases. I think a good example of how this occurred many years ago was with RBST, or recombinant bovine somatotropin. There was a lot of information out there about how it does or doesn't affect people and cows, and a lot of it was misleading, and that is no longer a tool available to our cattle farmers. Then I think my last 2 points are funding and relationships are important, right? When we respond to an animal health emergency, we are responding largely through USDA funds and Commodity Credit Corp funds. That leads to a lot of time spent on arguing over minuscule expenses while time-sensitive work is being delayed. And there's been some real challenges with that in Pennsylvania. There's also an inequality, right? We've got systems where companies can hire folks to do a job in response and then get reimbursed from the USDA. If you've got smaller farms like we do in some of our Pennsylvania areas, those farms don't have the workforce where they can call out 15, 20 people on a moment's notice and get them to respond to a barn. From that respect, the farm cannot provide those resources. The state cannot provide those resources and get reimbursed, and we can't contract them and get reimbursed, unlike would happen with a larger company. So that leads to a bit of an inequality and a bit of a vulnerability there. And then we're beholden to often arbitrary rules based on obscure or non-transparent fee schedules and payment scales. And we need something that we can do to remove red tape to help support our smaller and medium-sized growers. And my last point is federal agencies need to build stronger relationships within agriculture, and not just USDA. We enjoy a wonderful relationship with our local USDA folks in Pennsylvania, but that goes for all federal agencies that are relevant to responses, pandemic and animal disease responses. We need to get better relationships with our farming communities, better relationships with our departments of ag, and we need to do it before we have a response that we need to mount so that we can go forward with trust and with open conversation and mutual respect. Thank you.
Thank you, Dr. Hamberg. Dr. Hatcher.
Great. Representative Brooks, members of the commission, thank you for the opportunity to speak with you. And thanks to you and the staff supporting your efforts for keeping a spotlight on these threats that affect all of us, and for maintaining a dialogue across the aisle. I think it's really critical that we recognize that we are all working together against these threats. Your focus on accelerating medical countermeasure development and fostering coordinated biodefense leadership closely aligns with CEPI's mission as an international organization to rapidly develop vaccines against emerging infectious diseases, and I am speaking from that perspective today. Clearly, we're in an era of increasing epidemic and pandemic risk caused by a convergence of factors that I'm sure you're all familiar with. COVID-19 taught us that an effective response actually is going to require, in the future, will require a paradigm shift in our approach towards preparedness. Operation Warp Speed was a tremendous success, but it was only the first step. Preparedness is not a static achievement, and dormant capabilities in factories are insufficient for rapid pandemic containment. We saw that here in the U.S. during the pandemic with some notable failures of dormant facilities that were activated. Instead, we have to cultivate warm capacity that can surge during outbreaks
and pre-negotiated rules of the road that enable swift action. One of CEPI's chief contributions has been championing the 100 Days mission, which is an ambition to develop vaccines and other countermeasures in just 100 days following the emergence of novel pathogens. Recent modeling suggests that if a COVID vaccine had been delivered within 100 days of the publication of the sequences in January, it would have saved 8 million lives and an estimated $14 trillion. The scientific capabilities required to achieve the 100 Days mission, and functionally, I would argue, if executed well, to take the threat of epidemics and pandemics off the table, are within reach, but will require sustained R&D investment, enabling systems and policies and practices. The validation of new vaccine production technologies during the pandemic, coupled with the power of AI to accelerate target selection, product development, clinical trials, regulatory processes, and review, bring such a goal within reach. At CEPI, we are making coordinated investments across the different capabilities areas, from vaccine design to preclinical and clinical testing and biomanufacturing at scale. And crucially, and I think I'm picking up a point Dr. Khan made, these systems that will be required to respond rapidly are the same no matter if the outbreak is natural, accidental, or due to deliberate misuse of biological tools. Supporting the 100 Days mission supports U.S. biodefense goals in several critical ways. First, protecting Americans against all biological threats, regardless of origin, through rapid vaccine development capabilities against emerging pathogens will save American lives, and it will support American innovation. A lot of that important work will be done here. It also deters the development and use of bioweapons by reducing the perceived value of a bioweapon if a bad actor knows that we have the capabilities to respond rapidly and effectively. Secondly, the 100 Days mission strengthens U.S. and global response infrastructure to allow rapid response to outbreaks whenever and wherever they occur, and thereby helping to contain outbreaks at their source before they spread to the U.S. And finally, the 100 Days mission can support strengthening U.S. and global biosecurity and biosafety capabilities. CEPI, as an organization with the support of Global Affairs Canada, has recently issued our first biosecurity strategy. In 2024, we issued an implementation plan in 2025, and we are working with USG and international partners to strengthen biosecurity, biosafety lab capabilities, accelerate performance-based standards for biosecurity, and reduce sample biosecurity risks. Collectively, these efforts will reduce the potential for epidemics and pandemics overseas and protect American citizens. However, much of the global preparation and planning is siloed across health development and security sectors, and these communities do need to be brought together. We need to leverage our joint expertise, our resources and skills, particularly in the current constrained environment, to be able to prepare for the full spectrum of epidemic and pandemic threats. CEPI has been a vehicle for this type of collaboration and a convener in the international space, both with sovereign partners as well as non-governmental and multilateral partners. Let me just wrap up there, but conclude by saying, to sum up, even in the constrained environment that we are operating in now, this is a time of opportunity, but we have to choose to take that opportunity to realize the gains that technology and science can provide for us.
Thank you very much. I'm going to start out. Dr. Shalala, do you have any questions you might want to?
Just a quick one for Dr. Hamberg. I actually have questions for everybody, but I won't take up the time. Avian flu, avian influenza, you recently had to deal with it. Is there any difference between how you deal with it this time as opposed to other times?
So our response has certainly evolved as we've gotten better at it. We've added some new equipment to our arsenal. We've built better relationships and better protocols and better techniques. And the basics are still very much the same. What we desperately need are some newer tools or options for the largest of our layer houses. We still suffer from constraints. For example, lack of availability of carbon dioxide on the Northeast is a real hindrance for some of the bigger houses, and we've got to resort to other mechanisms for depopulation, things of that nature. So I'd say the principles are largely the same. The obstacles are slightly better. We've overcome a few of them, but not many.
Thank you.
Representative Greenwood?
Thank you. I want to address my question to you, Dr. Hatchett. I'm very intrigued by the comments you made about the 100 days facility. I think you said that the science and some other categories are within reach. So I'd like you to talk a little bit in more specifics about what we need to do to get there scientifically and otherwise. And then the second half of the question is, to what extent is this a U.S. Project, so to speak, or aspiration, and to what extent is it global? And are there other countries who are working on trying to achieve this goal?
Sure. Let me just say the 100 Days mission as an ambition presents scientific challenges and it presents execution challenges. And actually we're making progress on both of those. Let me talk about the proof case, I would say, for the science.
And just, if I may, quick concern, is this a private sector project mainly, or is this a governmental project, or is it both?
It is both, actually, I would say. CEPI has supported it. CEPI is funded by sovereign governments and foundations, philanthropies. Several countries, Korea, the UK, even the United States in the last administration wrote the 100 Days mission into their national preparedness plans. It's been endorsed by the G7 and the G20. It was a major theme of the 2021 G7. So it actually extends now beyond vaccines to include therapeutics and include diagnostics, to answer the second part of your question. The proof case, I would say, for the 100 Days mission, the whole idea behind the 100 Days mission is that we now have a variety of different vaccine platforms, many of which were validated for the first time during the COVID response. What's not as well understood about most of the vaccines that were produced during the response to COVID is that they all used the same fundamental vaccine design, which was a modification of the spike protein on the SARS-CoV-2 virus. And that modification of the spike protein was actually worked out by scientists at the National Institute of Health, not just for coronaviruses, but for a number of different related classes of viruses. And at NIH, they had been working with one of the partners who delivered a successful vaccine, Moderna, to develop a MERS vaccine, a Middle Eastern Respiratory Syndrome vaccine, which is another coronavirus. And they had basically solved the fundamental vaccine design problem for coronaviruses in advance. So when the sequences were released for the SARS-CoV-2 virus, Moderna was able to design what became the first generation vaccine, COVID vaccine, in 36 hours. They took the fundamental design, they adapted it to the new virus, and they designed the first generation vaccine in 36 hours. And Representative Brooks and I were in Davos, and 12 days after the sequences were released, CEPI made an announcement at Davos about our initiating support for vaccine development. One of our partners was Moderna, and what we were producing on day 12 after the sequences were released was actually the production of clinical trial material. And so that's how rapidly you can get to the production of clinical trial material if you're properly prepared for the virus family that the new virus emerges from. And so the goal now on the scientific side is to extend the number of virus families for which we have those fundamental designs already effectively in a library. The second challenge is the execution challenge. In COVID, it took Moderna 66 days from the release of the initial viral sequences to start the phase 1 clinical trial. In Rwanda, last year, CEPI, working with the Rwandan government, stood up a phase 2 clinical trial of a Marburg vaccine candidate. The vaccine candidate already existed. We weren't developing it de novo, but we were able, because we had been working on the execution side, on the practicing and the planning for the logistics side, we were able to initiate a phase 2 clinical trial that had gone through their regulatory process, gone through their ethics process, gone through clinical protocol development in 9 days. So 9 days from the start of the outbreak to the start of the clinical trial to first injections. And so if you take those two pieces, the being prepared for the different virus families and working on the execution piece, you get very close to being able to deliver the critical data to regulators within 100 days.
Thank you very much.
Mr. Weinstein? Okay. Dr. Hamberg?
Thank you. Well, I'd like to follow up on what you were just saying, maybe link it to a question that probably all of you could weigh in on, but maybe Clint Osborn would also have some perspective, which is how these very important goals and objectives that you have defined in our shared mission to strengthen preparedness, planning, and response to a range of biothreats, how the current fiscal and geopolitical environment is constraining your opportunities to actually be delivered upon. You said, the scientific opportunity is great, we have to seize it, but then we also have to deliver. Execution, you mentioned, but also delivery to the people who need it. And so many of your partners have been defunded with USAID's collapse and loss of other global efforts. For you, Clint, your preparedness and response efforts are no doubt also hindered by the fact that non-governmental and governmental entities at different levels have been defunded, et cetera. So how, again, looking forward, how can we think about making sure that we can really realize the opportunities that are before us to do a better job, to deliver on opportunities in science, and to reach the people in need?
Great. Thank you, Dr. Hamberg. Let me just preface this by saying I'm responding from my international perspective. I've been traveling a lot this year. I've probably been in 20 or 25 countries on 5 continents, talking to people in governments with different levels of income. And the one thing that, the strains on resources are very substantial across the board, and a lot of capability is being lost. Many of our partners have had to reduce their staffing, have had to close down individual projects or even programs, and it presents a real challenge. It also forces prioritization. It forces partners to think about how can we better coordinate our efforts with the efforts of others. I don't want to describe that as a silver lining, but the focus that comes with those kinds of resource constraints and the decisions that you have to make does present opportunities. And the other thing that I am hearing internationally is no one expects to return to the status quo ante. They are thinking about how to reassemble capabilities and to partner better, to work more efficiently going forward. I will just say, the constraints on resources are not exclusively driven by U.S. policy decisions. These are worldwide challenges. They are driven by security concerns that are being faced globally, and in some by structural challenges like demographic change that's changing the tax base in countries that have been major funders of this work historically. So this is a long-term structural challenge that I think people are now waking up to. It's going to be hard. I think we will see more vulnerability, particularly in the surveillance and threat detection and response space, where these things can degrade very quickly. But I do think even in the challenging environment, there are opportunities. And let me turn this over to you, Dr. Osborn.
It's really interesting. I was listening to your description of the 100-day focus, this sort of rapid sequencing and delivery process. And I kept going back to this conversation that we've had in multiple panels today, which is capability building, right? And capabilities we define in the emergency management space, but it's not rocket science. A capability is built when you have plans on what you're going to do. You have the organization and people, staffing to do it, which is in the public health space. The last panel talked really in depth about this, about the pinch point with well-trained people, but also the fact that public health is exceptionally broad, and it doesn't. There's this assumption that within public health you can move people between specialties and it's like fluid, right? Well, I did my graduate work in public health, and again, you do not want me reading disease curves, right? So it's not transferable. But so you got to have a plan. You got to have the people that know the plan, and you have to have the people that have the KSAs, the knowledge, skills, and abilities to execute their role in the plan. You have to have the equipment to do that. You guys are working with highly specialized equipment. I remember during COVID, our forensics lab said we need a Panther. I was so excited to see a resource request for a Panther because I thought we were buying a large jungle cat, and it turned out it was a highly specialized tool that was essential to the work that they were doing that we did not have. They had the capability to do testing. They couldn't do it quickly enough because we couldn't get it. So we ordered that, and then it was basically back ordered for a little bit. So you have to have the equipment. You have to have the training. So people have to know how to do their jobs, and they have to know how to work together in a rapidly changing environment, and then you've got to exercise that. And what we find is that in this space, you rarely have, somebody said preparedness is not a static thing. It's not a point you achieve and then you're done. We rarely have all 5 of those elements at top condition at all times. I think there are a couple of challenges that you raised, Commissioner. Specifically, I just want to speak to one. The current challenges we're seeing with uncertainty in our funding, uncertainty in grant cycles, we're seeing a rapid loss of knowledge in both the emergency management space, but I think it's safe to say in the public health space as well. And if I had to pick one thing that really concerns me, it's not our ability to buy widgets right away. We can figure out, I think as we demonstrated during COVID-19, we can figure out a way to restart some of that industrial base. We are losing a lot of people who know how to make widgets and make widgets work and then do all of the other steps of capability building. And we're losing them at an increasingly rapid pace. And I think that's a real concern because if we can't build capacity across those 5 elements, at this point, it's just a risk management discussion. What risks are we willing to accept as a nation, as states, as local jurisdictions? And that's an evergreen conversation. The current administration is very focused on border security, right? Well, that does have some benefits that we've talked about a little bit today, but we are dealing with a finite pot of money at some point. And I think one of the challenges we're going to continue to see is where this group of sort of like-minded folks are comfortable or are uncomfortable with accepting risk in this space is competing with a lot of other spaces. I think, deeply about what's happening in Texas with flood recovery. I love this, by the way, that we never get recovery right? We're not committed to it. But I think we're competing especially with emergency issues, emergency and disasters. We're competing with the urgent as well, right? The tyranny of the urgent is in front of us all the time. And in an increasingly challenging environment, finding the resources to make sure that we have the capabilities for rapid vaccine development is competing with alert and warning systems for flood operations. It's competing with climatology research and study. And what scares me is that all of these things are connected, right? Zoonotic disease and climate are so closely linked. And we're losing, as we lose basic component production, which I wrote down, as we lose basic component production, it's not just materials, it's also knowledge. And I think that, for me, is the thing, Commissioner, that really concerns me is our base component production for knowledge. When we stop training new people, when there are no pipelines to careers and jobs in these spaces, we're hurting now. We're hurting ourselves 8, 10, 12, 15, 20 years from now.
Thank you very much. Asha, any questions?
Yeah.
Can I add a quick note to that about constrained environments to help you think about really not just partnerships, but what are priorities, right? So workforce is a clear priority. The number one risk remains influenza. It will always be influenza. And so if we have to invest in something, let's make sure that we're ready with a universal influenza vaccine that looks at multiple different platforms that allow us to get to an influenza vaccine instead of prematurely deciding that this is the one platform that we're going to go with. So again, I think prioritizing helps in a constrained environment.
Okay. Ali, I wanted to ask you just quickly, your center started out, putting aside the academic part, as one of the Ebola response centers back in the day, and it's grown and it's added, more capabilities throughout the years. And it's, now it's called something else. I think we have 6 of them throughout the country. Do you think that we need more of those, or do you think those 6 can handle it in some sort of stratified situation?
Thank you for that question. And that's actually a great example of an initial federal investment in 2009 in saying we're going to set up in terms of preparedness dollars that went out nationally, and the University of Nebraska and the state of Nebraska decided to use it to create a biocontainment site, which then was where first Ebola patients came, but eventually most people don't remember the first SARS patients in the world when they came to the United States came to Nebraska. And so that's now the basis of the National Quarantine Center in Nebraska and a network across the U.S. that does need to be expanded and thought of not just around biocontainment, but I would say multi-jurisdictional assistance with preparedness and response activities. And so I think we've got a good model there for regional support. It just needs to be expanded. Multiple administrations have been supportive of this, and so I'm hoping that we will continue to see this increased regionalization as a way to address some of these gaps in workforce and other issues.
Mm-hmm. Okay. And Richard, CEPI's been going on for a while now. It's been very successful. What else do you think the coalition needs to grow and do even more in the future?
Resources, of course. Thank you. That's kind of a softball. One of the things that I think the great opportunities that I see, and resources are always good, but there, after COVID, a number of countries now care intensively about medical countermeasure development. And when I was working in the U.S. government, my career before CEPI was in the U.S. government at BARDA and NIH in the White House. We tried to get allies to share the burden of medical countermeasure development, and largely unsuccessfully. It was a U.S.-led endeavor and an almost exclusively U.S.-financed endeavor. But now we have partners in Canada, in Europe, in Japan, in Korea, in Singapore, in Australia, setting up enterprises, institutions, or bringing existing institutions together in new ways to support medical countermeasures development. There's also been a convergence around this idea of using the virus families as an organizing principle for thinking about how to advance preparedness against different threats. That's a big but a finite problem, and that is a perfect type of problem to share amongst allies, like-minded allies who now have institutional resources that they can dedicate to addressing the problem. And one thing that I would really, really love to see internationally on this issue, and this doesn't have to work through multilateral institutions, I think it's distinct from that, is U.S. leadership. The U.S. has a concentration of financial resources, it has a concentration of scientific resources, it has thought leadership that has stimulated the rest of the world. The rest of the world is now buying into concepts that were originated here and putting money on the table. But that effort needs to be organized. CEPI as I like to say, little CEPI can convene meetings, and people like us because we're harmless and we don't have any control or any authority over anybody. So we can convince people to sort of come to the table and talk with us. But having a government like the United States take real leadership and drive momentum and progress internationally on this would vastly accelerate global progress.
So since I asked the softball question, I'll ask you the more difficult one. If the United States does not take leadership, which other country should or could?
The answer is not China.
Okay.
That's funny, because that's the one I was going to suggest.
I don't.
Because
see,
somebody needs to.
Yeah, no. Somebody needs to. I mean, I think I don't see China stepping into this role. They have tremendous scientific capabilities, financial resources. There's a very dynamic bioeconomy in China that is very attractive and exciting for a lot of the private sector partners. But for whatever reason, they haven't stepped into this role. So I think Europe right now with HERA, which is the European equivalent of BARDA, is probably the most prominent. But they tend to be domestically focused, and their structural setup with the loose alliance of the countries and what they have to achieve internally to somewhat inhibits their ability. I mean, they are trying, but they're not structurally positioned in the way the U.S. is.
Okay, I'll just ask two more quick ones. Alex, we've been talking about the cost of foot and mouth disease and mad cow disease coming to the United States since at least the Bush administration, maybe even the first Bush administration. We see cost estimates come in and people freak out. There's one or two op-eds and then it comes back down again. But the motivation for doing something about this is economic more than anything else. When we hear anybody with a veterinary background or an agricultural background, it all keeps coming back to this. And the numbers start in the billions, not little teeny tiny millions. What do you think it's going to take for people to actually believe? Because usually we say if you can put a dollar amount on it, people are motivated. But yet we haven't really seen it. What do you think?
There's been, a really good resource for that is the USDA Red Book itself. There's a series of estimates of what an introduction of foot and mouth disease would do to the U.S. in damage. And if I remember correctly, a single introduction into California that were limited in California was estimated, if I recall correctly, about $60 billion damage. A single introduction into Kansas was about $120 billion damage. And then a nationwide multi-state introduction would be well over $200 billion in damage. The cost, though, is more than just the billions of dollars. There's been some research out of, I believe it was either Kansas or Nebraska several years ago, where they looked at commodity markets. If we were to suddenly pull out a huge amount of our major consumers of soy and corn from the market entirely, that could certainly put commodities into chaos, and that would potentially disrupt our food supply chains and food production chains profoundly, to the point where we'd start talking about more than just not having money.
So what's the answer then? More information about the cost?
I think it's more information about the cost, but I think it's also more looking at what happened elsewhere in the world and how they responded, right? That 2001 introduction into the UK, not only did it cost billions of damage in a comparatively small country, but farmer suicide rates skyrocketed. There is a huge public health component to this. Food security is not just an agriculture problem, and it's not just a veterinary problem. It is a human problem and a public health problem as well. How to get more people talking about it, that's not my area of expertise. I would love to have a better answer for you on that. But we do need more awareness, and I think talking about it and getting public attention to it is absolutely critical, because we've got way too many threats that are very close to home right now. And for some of them, we're fairly well situated. For others, we've got a long way to go before we're ready to mount an effective response. So,
okay. I'm just going to ask one more. Clint, pulling public health doesn't necessarily consider itself part of emergency management, despite the fact that it winds up managing emergencies quite often. Here in the district, how have you been able to pull the public health department and those assets and people into the emergency management enterprise, if you will?
We're fortunate in that our Department of Health, DC Health, has they've got a full administration, just the same way they have licensing and child and maternal and disease prevention. They have a whole administration for emergency preparedness. And it's had, over time, it's had very progressive leadership. They train on the same doctrine we train on. I mean, you've heard a number of other folks on this panel and in other panels. They're speaking emergency management. They're speaking core doctrine. And I think that we're fortunate in that way, but I think there's also, it's leaders' intent. It's leaders' intent that we don't silo, that we do work together. We're in the process right now of having our Intelligence Fusion Center begin to continue to expand into support to the public health community. And our Fusion Center analysts need to learn to speak public health, and our public health folks need to learn to define their key intelligence questions. But those types of ongoing relationships, again, it comes back down to people, right? AI can't solve for this. It comes down to people and learning different mission spaces, and most importantly, just seeing how connected everything that we do is. And you know, I started my career in a small-ish suburban community in North Carolina, and even then, I had an excellent relationship with our public health emergency preparedness coordinator. So for me, that was part of my upbringing, is that, you know, you're public health coordinator, and she covered 2 counties, right? So for me, it's always been, you know, first you look inside, and then your next phone call is the health department, right? And I think it underscores something, that emergency management, if a tree falls in the woods and it's not there to hit anybody, it's not an emergency. It's when we have threats and hazards that result in consequences to human beings and animals by extension, right? And our environment, that we have an emergency. A hurricane in the middle of nowhere that doesn't impact people it's not an emergency. It's not a disaster. It's just a phenomenon. And I think that increasingly there's far less of a hard line in my mind. I'm looking at Mr. Barbieri around here somewhere, someone at DHS who's worked with us in the health security area. There's a lot less, I think, of a hard line anymore between emergency management and public health, because we're all here for that same core mission, which is protecting, you know, life, property, and the environment.
Okay, thank you. Thank you.
Thank you all so very much. Appreciate you. Thank you.
All right, we now like to introduce our final panel for the day. We have with us Dr. Matthew Hepburn is the Executive Vice President of Research and Development for Panther Life Sciences. Taylor Sexton is the Executive Director of Medical Countermeasures Coalition. And Joe Bacina is the Policy and Research Director for the National Security Commission on Emerging Biotechnology. Thank you all for joining with us, and Joe, we'll start with you.
Thank you, and thank you for having me here to talk about the future of biodefense, which is profoundly tied to our Commission's focus, the intersection of biotechnology and national security more broadly. My name is Joe Bacina, and I'm the Policy and Research Director at the National Security Commission on Emerging Biotechnology. Our commission was created by Congress in 2022 on a bipartisan basis to develop recommendations to advance U.S. leadership in biotechnology in relation to national security. Our commission defines national security broadly. We understand national security to encompass traditional defense issues, but also economic resilience and competitiveness, as well as health security, food security, and energy independence, all of which are critical for America's long-term security. In April, we released our final report, which assesses our position in the global biotech race and provides recommendations for how America can maintain and in some cases regain our lead in biotechnology. Leadership that's necessary to make our country safer, more secure, and more prosperous. We see our recommendations as complementary to those produced in the Biodefense Commission's National Blueprint. A strong biotech ecosystem is a prerequisite for an America that's prepared for and resilient in the face of biothreats. America should be the biotechnology powerhouse in the world. After all, modern biotechnology is an American invention. and we've led the world for decades. But our report found that America's biotechnology strengths are atrophying as our adversaries, particularly China, are surging ahead. To secure our biotechnology leadership and promote our national and economic security, our top-line recommendation is that the U.S. government commit $15 billion over the next 5 years to unleash private capital and drive innovation in the biotech sector. In total, we produced 49 recommendations focused on protecting and promoting biotechnology. Promote means supporting U.S. biotechnology innovation so that we can outrun our adversaries, while protect means preventing the loss of our technological leadership while also preventing risky supply chain dependencies. Our recommendations range from traditional biosecurity to data use to workforce development, and today I'd like to focus briefly on 3 of these recommendations, all of which have downstream effects on biodefense. First, data. Biological data are the foundation of biotechnology advancement, especially as AI accelerates biotech development. Just as we protect our oil reserves or our agricultural supply chains, we must treat sensitive biological data as the strategic national resource that it is. This means preventing adversaries from gaining access to our data and better utilizing the data in our own biotechnology ecosystem. Our report makes several recommendations to that end, including creating a web of biodata, which is a single point of entry for researchers to access high-quality data, developing standards to ensure that biological data is AI ready, and protecting U.S. biological data from adversaries while simultaneously promoting data sharing and collaborations with our allies and partners abroad. These data-related recommendations would help cement the U.S. global lead in biotechnology and then feed back into our R&D for biodefense capabilities, such as diagnostics and medical countermeasures. Second, our report also makes recommendations relating to grand challenges. We call for 2 sets of grand challenges, one to make biology predictably engineerable, and one to advance the science of biomanufacturing scale-up. We need to unlock leap-ahead capabilities in these areas to get biotech to that ChatGPT moment, where researchers can unleash its full potential to secure our food supply, health, and defense capabilities, including those related to biodefense. The findings and results from these grand challenges will directly push forward our biotechnology and biodefense ecosystems, helping achieve goals like those set out in the Apollo program for biodefense that your commission first proposed in 2021. A third recommendation focuses on the governance of the biosecurity, biosafety, and responsible development aspects of biotechnology. We must move away from our current fragmented, reactive, and increasingly outmoded governance system. To keep pace with biotechnology advances, our report recommends consolidating and streamlining oversight processes for research and innovation. To keep this oversight updated, we recommend coupling it with an ability to assess emerging threats and rapidly innovate the technical and organizational capabilities needed to address them. This consolidated and proactive governance system would have 5 main functions. First, to identify emerging risks and vulnerabilities. Second, to fund advances in biosafety, biosecurity, and responsible innovation. Third, develop and incentivize best practices for the industry. Fourth, consolidate and oversee related policies. And fifth, work with the international community across all these efforts. This system would also support America's biodefense efforts, aligning with R&D for countermeasures and biosurveillance, and also directing data gained from biosurveillance of the innovation system. This will help towards efforts to protect the American people from biological threats. Finally, in addition to those 49 recommendations in our report, the Commission also published a series of additional considerations, including one related to biosurveillance. I think I'm piling on here, but robust biosurveillance capabilities make both our biotech sector and our biodefense stronger and more robust. An effective biosurveillance program would lower the time between outbreak and identification, making deployment of countermeasures more effective, mitigating the undetected spread of a stealth virus, and providing valuable scientific data. The best path to improving our biosurveillance would be for Congress to create a pathogen-agnostic, scalable, and global biosurveillance program at the Department of Defense. In closing, our commission believes that America can maintain its position as the top biotech power in the world, and in doing so, keep our people and our allies safe from biothreats. But to do so, we need to act now. Thank you to the Biodefense Commission for bringing us together for this important conversation about how we can drive that action together. I look forward to your questions. Thank you.
Thank you, sir. Dr. Hepburn.
Great. Well, a massive and huge thank you to the Commission for hosting us today. I've been a huge fan ever since I was an infectious diseases fellow 20-some years ago. And throughout my government service, I have watched this Commission make so much impact over time, and I think this could not be more timely. Today, I was looking at the title, and it said Danger and Opportunity, and I thought, you know, should I talk about danger or should I talk about opportunity? And I was just in a mood that I think we should end on a bit of a good note. At least this is how I feel. So, and those that know me, I tend to bring a bit of optimism. So that's what I'm going to do. Wanted to, and especially we're talking about science and technology. It's so exciting, the promise. I had a chance to serve at DARPA for 6 years, and so that changed my life forever. And so I'm going to bring a little bit of DARPA awesomeness maybe to this talk. And it's a little bit less about what we should do in the future, but almost reminding us who we are. And I want to draw on two examples. First, from my experience with Operation Warp Speed, and second, from my experience over at the White House Office of Science and Technology in the previous administration. So I did have a chance. I served as vaccine lead at Operation Warp Speed for 18 months, spanned both administrations. There's a lot of people who talk about the great things that were accomplished, and I kind of want to emphasize things that I don't hear people say as much, but I think were very meaningful to me, and hopefully you'll agree that it conveys sort of what can be possible. The first is public-private partnerships, and granted, total cliche, and I don't know how many times it's been said today, and it gets said every time. But the point of Operation Warp Speed wasn't that it was led by a few people. It wasn't about the political leadership. It was about America. And it was about literally thousands and thousands of people who participated and put their heart and soul into driving these vaccines and to accomplish something that no one thought was possible. We started at that Rose Garden ceremony in 2020. We thought it was possible. No one else did. But the only reason it was is because literally hundreds of thousands of people signed up for phase 3 clinical trials. We visited, I want to tell you an anecdote about going to Bloomington, Indiana. We visited Catalent, and Catalent was doing the fill finish of the Moderna vaccine. And we visited, and my goodness, it was so inspiring because they were working 24/7. The entire facility was humming. And they said, we have been going 24/7 for 3 months. And you know, that's what Americans do during a crisis, when we rally, when we work together. And so that's what public-private partnership means to me. And I want us to, you know, we need to do more of that, but we can do that. We have a recent example where we did. The second lesson from Operation Warp Speed, people talk about the foundation of basic science discovery. Hugely important, impossible without it. What doesn't get as much coverage is that we had an organization called BARDA, the Health and Human Services, that had been established decades before. And it was a shining moment for that organization because we instantly had the mechanisms, the contracting, the experience, the ability to procure that was already in place. And it had been ready for years. And the BARDA team was a shining contributor. I mean, they made so much of a difference in Operation Warp Speed. And what was interesting is that one of the main lessons in many of the other countries from their COVID experiences is that they needed a BARDA equivalent. And if you look around the world now, you'll see many countries that have now, European Union, Canada, Japan, just to name a few, that created a BARDA equivalent because they didn't have that for the COVID vaccine response. I think it's a great lesson in what was done with legislation decades before, how much it paid off, and how we need to, even just maintaining it, how important that is. The third is that, again, I served 23 years active duty Army, and so one story I don't think that gets told as much is the contributions of the Department of Defense. And not only, it was twofold. It was first because I think some of you know, and I do see one of my old mentors, Gray Hepner, in the audience, who I've known for decades. But the Army has sustained the Department of Defense has sustained a military medical research capability that whether they're working on malaria or combat casualty care or trauma or traumatic brain injury, all of that capability all of those people with decades of experience in vaccines, contributed massively to Operation Warp Speed. Very few people know that. And so when we talk about sustaining capabilities, I think we forget that having the Department of Defense have this amazing medical research system, but more specifically, a medical research system should be sustained. Furthermore, the idea of Army leadership, and I say Army particularly because I'm talking about the Army Material Command and the 4-star General Gus Kerna, who led the operation. He was the Chief Operating Officer of Operation Warp Speed. And again, the story that's not told is that his leadership, with really the best of the best in terms of Army logistics, are the ones that made the distribution happen. They could not have been better. They didn't know much about vaccines when they started. It took them like 2 weeks. But they didn't have to know vaccines. They knew how to lead. They cared about America, and they made that type of contribution. So this idea that the Department of Defense, specifically on biodefense, we know they should be engaged in such. But let's not forget that the Department of Defense, in that time of crisis, should be utilized in all aspects in that time of need, and we should plan for that. That should be part of our planning process. I do want to highlight also briefly my second experience, which was over at the Office of Science and Technology Policy, and this was after the pandemic. And one of the privileges of that role is that in the post-pandemic conversations, there was a strong impetus to try to build what we call these regional biotech ecosystems. And what I want to highlight there is that this was the idea of that there isn't just a few places in America where all of the biotech is and where all the innovation is and where all the resources are, but that we should take advantage of so many different powerful communities, and we should resource those, and we should highlight these great examples. So I basically did a listening tour, and I got a chance to see, we visited North Carolina, we visited the state of Washington, we had great conversations with Oklahoma and Indiana, we had an amazing trip to Puerto Rico. The common element among all of those was extraordinarily talented people. It was a university ecosystem and STEM education that provided the foundation. It was federal funding that supported incubators and sort of giving the new biotechs a chance. But it was these state biotech associations. They probably weren't brought up today. They're not part of the story as much, and I think we need to make them more part of that because they provide that. There's such a contribution to the future innovation. I just want to leave you, hopefully those anecdotes show a little bit of enthusiasm and a little bit of inspiration. I want us to not forget that America is still the best place in the world to innovate, to solve problems, and that, if I'm placing my bet on how we're going to respond to future pandemics, it's going to be with American ingenuity.
Thank you, sir. Mr. Sexton.
Thank you. It's always lovely to follow Matt, his optimism, and not at 1 a.m. in the wonderful Humphrey building. So, good afternoon, commissioners and ex officio members. Thank you for the opportunity to be here. I'm Taylor Sexton. I'm the executive director of the Medical Countermeasures Coalition. MC2 is an alliance of biotechnology innovators, academic institutions, and nonprofit organizations working across the medical countermeasure enterprise, from research and development to biosurveillance and threat assessment, to procurement and the advancement of a resilient supply chain and domestic manufacturing. Our mission is straightforward: to ensure that the United States is prepared to respond to high priority threats to national security. As we meet today, there's a broad agreement that the biological threat landscape is evolving faster than our current systems are designed to respond. But, as Matt said, I'm optimistic because we've already seen what's possible when we get a lot right. And during the COVID response, along with Matt, I had the privilege of serving at ASPR under the 45th administration, where I worked alongside outstanding leaders such as Matt, Dr. Bob Kadlec, Dr. Perna, Dr. Slowey, and many others who helped build and execute Operation Warp Speed. It was one of the most successful public-private partnership undertakings in U.S. history, and it worked not because of any one agency or office, but because we had a unified mission, clear requirements, and real-time coordination across government and industry. As Matt noted, the structure, one built on collaboration, shared risk, and speed, it was essential, and it was a spirit of partnership that turned the blueprint and the MCM enterprise into life-saving countermeasures in really record time, and that ethos must continue. And looking forward, I'd like to highlight, 3 areas where MC2 believes that we can apply those lessons to build a stronger, more responsive biodefense enterprise. First, we must continue investing in adaptable, threat-agnostic capabilities. We've learned that waiting to identify a specific threat that before we act is too slow. Instead, we need platforms that can be rapidly adopted when new threats emerge. That means designing funding mechanisms, regulatory pathways, and procurement systems that reward flexibility and speed. We support efforts to accelerate the development and deployment of countermeasures within the earliest days of an outbreak. But speed alone isn't enough. It requires practice coordination across agencies. And with the private sector, there must be innovation, manufacturing, and infrastructure building that occurs early. Just as important, we must modernize and integrate our threat detection infrastructure, including genomic and data-driven tools that can rapidly identify emerging threats, novel variants, or unusual signals before they become broader public health emergencies. Second, we must rebuild, sustain our domestic manufacturing and supply chain capacity, while also strengthening partnerships with trusted allies. Today in the U.S., we still depend on foreign sources for many of our products, sometimes from countries which interests don't align with ours. BARDA, the Industrial Base Expansion Supply Chain Office of the NASPR, and the Department of Defense have stood up critical manufacturing capacity, some of it established under Operation Warp Speed. But without consistent demand, our sustainment mechanisms, these capabilities are not maintained. This challenge extends beyond pandemic threats, from seasonal and pandemic influenza to smallpox, anthrax, and we must ensure that procurement and domestic production capacities are all aligned, not just during emergencies, but between them as well. Third, we must modernize our approach to the Strategic National Stockpile. The SNS remains one of the most important tools we have in a national emergency. Its mission is essential not only to rapidly deploy countermeasures, especially those within limited commercial markets, but as a deterrent that reinforces our preparedness structure. But to be effective, the stockpile must be well-funded and ready to evolve. That means aligning closely with nation's most pressing threats, involving coordination with commercial partners, and strengthening its ability to procure, sustain, and deploy MCMs at scale. This is especially true for high-consequence threats like smallpox and anthrax. Specialized countermeasures that require long-term government stewardship to remain viable, effective, and scalable at crisis. The stockpile must remain under ASPR's purview. It would be difficult for any single state to independently maintain the scale or situational awareness needed to manage these assets. The federal government plays an irreplaceable role in ensuring a cohesive nationwide response when states call. We should also expand our ability to support real-time response by pairing rapid diagnostics with point-of-care treatment so that countermeasures reach patients faster. That kind of delivery system Americans expect when they walk into a clinic or hospital that can also be used in need of a pandemic. To make that possible, we must invest in better integrated data systems like those built during OWS that connect threat detection, inventory visibility, and response operations so decision makers at every level can act with speed and confidence. Let me close by saying that the Medical Countermeasures Enterprise is a pillar of national security, which is why we're all here today. And as we've seen before, when we align public and private efforts and invest in scalable, flexible solutions, we save lives, we prevent disruptions, and we lead globally. The next challenge will not look like the last, but we have the tools, we have the expertise, and the partnerships to be ready. The Medical Countermeasures Coalition and our members stand ready to help realize that vision. Thank you for the opportunity to be here today.
Thank you. Let me start with the questioning, and I'll start with you, Joe. And my bias that comes from running the Biotechnology Innovation Organization for almost 15 years will be betrayed here. But you talked about the U.S. biotechnology sector atrophying. And clearly, one of the reasons we've led the world, some of the reasons we've led the world is because of NIH funding, incredibly important. That's the push, the beginning of the basic science and research. And on the other end of it, the ability of investors, whether they venture capitalists or otherwise, to believe that they can get a return on investment in a process that is highly risky. Vast majority of biopharmaceutical projects fail. So my question is, does your so now we have a couple of threats on both ends. One is the NIH funding crisis, and the other is that this administration and the previous administration have favored price controls rather than looking at the real problems that are driving pharmaceutical prices, like the PBMs, for instance, and others. Did your report, and I apologize, I haven't read your report, does your report take positions on those two issues?
Yeah, well, first I'll say, glad to get you a copy, and for anyone else, it's biotech.senate.gov. Please check it out. We don't really take positions per se on either of those two. They're somewhat out of scope, but I can tell you that I agree with some of the financial challenges that you mentioned about the biotech sector, and I'll talk briefly about a few recommendations that I didn't mention in my remarks. We have a sort of framework where we look at it from both the demand side, the supply side, and also the infrastructure support side. So on the demand side, we've seen higher interest rates. We've seen an environment where venture capitalists are a little more reticent to invest than they have been in the past. So one of our proposals is for an independent investment fund. This would be government funded but privately run, a very similar model to Incutel, or if you're familiar with Biodefense and GHIC. This, I think, would be important not just for biotechnology, but for other critical and emerging technology areas. The goal there is to crowd in private capital, not be a replacement or crowd out. And it would be designed as an evergreen fund with a starting allocation of $1 billion placed at the Department of Commerce. On the supply side, feedback that we heard from the industry, I'd say especially when we get into non-pharma biotech with novel, say, synthetic biology or biomanufactured products, is this challenge of getting the first confident early-stage customer. Maybe a little bit less of an issue in the biopharma space, but we propose commercial offtake agreements and advanced market commitments, something that was used to great effect at Operation Warp Speed, to help use government's buying power for products the government needs anyways, to sort of serve as a catalyst. And then lastly, on the infrastructure side, we found that it's a particular challenge for scale-up infrastructure for biotech companies. It's not something that VC or PE firms are usually willing to fund because it's CapEx. So we've proposed a few different things, including a network of bioindustrial product scale-up facilities modeled on a successful example that we've seen in Europe, the bio-based European pilot plant. We want to expand our capabilities here at the U.S. And also design and develop new facilities.
Thank you, sir. Let's turn to Operation Warp Speed. And I had a tiny role in that in early 2020, then HHS Secretary Alex Azar called me at home because of my role at Bio, and he said, if we were to create a Manhattan Project to make vaccines for COVID, who should run it? And after a little consultation, I called Monsif Slaoui and said, would you be interested in this? And I can only report this because it's been written that I said, may Secretary Azar call you? And he said, yes, he may. He hung up the phone and turned to his wife and said, shit. Because he knew that he was now going to enter the intersection of science and politics, and it was going to be an interesting process.
And he was going to lose millions of dollars in stock options.
Yes, yes, yes.
Which he gave up.
Yeah. So, obviously, Operation Warp Speed was stunningly successful. But since it's been shut down, the question is wrestled with all of the time. What happens if we need Operation Warp Speed tomorrow? And what are we doing and what are we not doing, we should be doing, to make sure that the second that we need, that we face another moment like that, Operation Warp Speed or its successor can be stood up as quickly as possible?
Yeah, happy to. And Taylor, I'll lateral to you after this. I remember, I really wanted to tell this, and it's the last panel of the day, but I remember vividly when we got, you remember Pfizer released their phase 3 clinical trial results, and it was much better efficacy than anybody expected. It's a great safety profile. And we were like, is that just a one-off? And then Moderna, a few weeks later, released theirs. I vividly remember when I got the call and heard about that. And I will always, the rest of my life, I'll say, anything's possible. And I was like, what's next? Malaria, TB, HIV, like the opportunity for us to rally and to, mitigate, eliminate, whatever words, around not only infectious diseases, but health in general. I love how Operation Warp Speed can be used as a rallying cry for doing that. And I can't tell you the number of times people said, we should do an Operation Warp Speed for Alzheimer's, and we should do this for breast cancer. And I've always said, yes, yeah, we should. And whether that's a small scale effort or a massive effort, I think that's not as much the point. The point of it is an absolutely integrated effort between the public sector and the private sector, where a community is working together and is determined to meet the highest standards of safety, which we always did. We met the highest regulatory standards. We had clear regulatory guidance. That's another critical part of all of this. But that we were able to achieve something that didn't take 10 years, but it took a year. And so the answer to your question, and I think, what I would love to see is us do more of this. I mean us as a government, but I also mean us as a society. And more specifically, you can call them mini sprints or whatever we come up with. But you can imagine saying, can we do an Operation Warp Speed for next generation malaria vaccines? And then work together, and in that case, really rally the international community. We heard from Richard Hatchett at CEPI, for example. But using those, tackling other diseases, and we have plenty of choices, but tackling other diseases, I see as, if you will, practice sessions. And the more that we do that, the more that we get in the habit of that, the more, frankly, where we have the Health and Human Services and Department of Defense work together, and assign a bunch of Army guys for a year to work on something. And it's less important what that disease is, and it's more important that we're exercising it. And I think we should. And I think we should, I'd love to think beyond the infectious diseases threat and go after breast cancer and say, can we do next generation immunotherapy against recurrent breast cancer? And people are like, well, that's not biodefense. It doesn't matter. It's the concept. And I think we should continue to exercise it.
Thank you.
Yeah, and just to feed off, exactly what you were saying, Matt, I think the interagency coordination was a huge part of that, right? And we were all together every day. I mean, we made the best friends in life because we were all working, hand in foot, all together, and we had a lot of fun doing, but it was really, really important, fulfilling work. And I think ensuring that doesn't atrophy is a big part of it. I saw afterwards, you can see that especially coordination between DOD and BARDA sustained for a while afterwards. There were a lot of contracts where BARDA and DOD were doing projects together. BARDA was helping fund it, and DOD was using OTA authority to be able to execute those contracts. And we could see this collaborative network exist. And some of that was due to some of the relationships that were built during Warp Speed. I mean, I think Matt calls it the transfer portal, like all these wonderful people that all were there at the time, and we were working on this together. And those connections were really important. So finding ways to exercise that, especially for biotech, and if you think small biotech and the innovators, they're running from agency to agency to figure out where they fit best. And it's really challenging going between the material threats that are at BARDA. Does that fit with what DOD is doing for the warfighter? And where does that overlap? And where can we better maybe align both of those objectives? I mean, I would love to see a world where JPO and BARDA were jointly funding projects and had one website where everybody was in one place and working through things at the same time, and aligning what DOD needed for the warfighter while what HHS needed to protect our Americans domestically. So I think the more that integration is doable, the better off we'll be, and we'll be ready for the next Warp Speed when we need it.
Thank you much. Donna, questions?
Yeah, I want to go back to the NIH point, because none of this would have been possible. I mean, we know how to guarantee markets. We know how to throw billions of dollars in. We know how to put together a team. But without the deep investments originally for AIDS research and the Vaccine Center, you wouldn't have had the basis for doing any of this in a year. So and you can't run with Alzheimer's or anything else unless you have the fundamental science that you're building on. So making sure that Americans understand that link, that technically we may be able to run with basic science, but unless it's done, and it takes years to do it right, we never did find a vaccine for AIDS, really. We found some treatments that were successful, but we never found that vaccine. But in the process with mRNA, we found enough so that we could run with the COVID vaccine. So the question is, how do we make that link, and how do we understand that that it's not just money or organization? You have to have the original science.
Yeah, so I guess we say it everywhere we go. So this is a good place to start. So I'm glad you brought it up. foot stomp, quadruple, triple. Let me just try a couple clarifying points, but just basically going to reiterate what you said. So the first is this idea of the foundational investments, even if they weren't in necessarily COVID, but they were in something related like human immunodeficiency virus, gave us fundamental understanding of immunology, gave us clinical trials with networks, both domestic and international. Little people don't know how we leverage those HIV clinical trials networks to do the COVID vaccine work. They were set up, they've been in place for decades. They were, as we talk about the highest evidentiary standards for how to treat and how to prevent HIV, they have been in place. And it was always a insistence internationally that no matter where you were in the world with HIV, if you were on a clinical trial, it was done to the highest ethical standards. I mean, there are so many examples, but it's also just learning how the immune system works. And all of that foundational research contributed to Operation Warp Speed. And there's no doubt about it. There's a specific group at the NIH called the Vaccine Research Center, or VRC. At the time, it was led by John Mascola. Barney Graham was chief scientist. I felt strongly compelled to say their names because not only did they do the foundational work, they were leaders on our Operation Warp Speed team. They were advising us on a daily basis on all aspects really of the science to support the accelerated vaccine efforts. And again, I know everybody says it all the time, but we're going to say it again, is that to build the foundation of that academic medical research, both in the NIH and both across all the universities that they support, you have to build that over decades. You do. And you have to make a firm commitment, and you have to be unwavering in that commitment if you want the results.
And you have to have a bipartisan Congress that's willing to double the NIH budget as they did in the 1990s. Which made a difference and started the vaccine center.
Yeah, I'm glad that, sorry.
For AIDS research. Extraordinary.
Yeah, Secretary Shalala, I just wanted to make a more general point to your question. We coined a term at the commission called bioliteracy. And I think it's something that we're sorely lacking both for the federal government and for the general population. This idea of having a basic proficiency in how biology and biotechnology works. And I think if we were able to implement some of our recommendations, like standing S&T advisory body for Congress, training for federal workers who touch biotechnology in their daily jobs, some ideas maybe for the broader public as well, it would go a long way towards helping people to make that link and understanding the role that basic research plays and everything that comes downstream of it.
If I could just mention, we were remarkably fortunate to have a platform that was there, and we had something to work from. And I think looking forward, how do we further develop platforms is going to be really important as well, right? But both on a regulatory standpoint and even for advanced research and development, as we know, BARDA funds things based on material threat determinations, and when that, that's sometimes difficult because it's harder to do that as far as to platform. And FDA approves on product, but we need further guidance to do that more broadly for platform-based products.
Senator.
Well, thank you, panelists, for yet another outstanding presentation today. I have so enjoyed not only your presentations, but the answers you've been giving to our commission members. And Matt, thank you especially for the shout out to BARDA. I think they ought to be more celebrated and more highlighted than they are, and they're the unsung heroes so often. We reference so often the importance of public-private partnerships, and I think rightly so, but I really don't know that we have acquired the specific criteria that would determine the success or failure of a public-private partnership adequately as we look, especially in the scientific context. If you were to give us your specific criteria on how one judges the success of a public-private partnership in this context, what would that be? And let me just ask each of you for your answer.
I'll start. Yeah, I was hoping for the hard question at the end of the day. There we go. It's a hard question. It's the right question. I'm going to say I think we can put it. Let's put it into two buckets. I think the first bucket will be sort of the if you will, the benefit to the American public And then the second is more of a kind of creating an ecosystem of innovation. And you guys can certainly pitch in on both of those. I think in the near term, I mean, I do think results matter. And I think the idea of saying, you know, if we are going to be a long-term investment partnership, one of the things I always used to say at DARPA, and I know probably most government servants feel the same way, like every taxpayer dollar is precious and should be treated as such. And so our job as government, you know, program managers and contracting officers and things like that is that we are getting the best deal for the government and the American people, and we need to live by that every day. And when we don't, you know, we should be held accountable for that. So I would say that we do need to, you know, results matter. If we are partnering to make a vaccine, we expect those people to make a vaccine. As has been brought up, you know, it's really hard to make a product and to take it all the way through. So there is a bit of a, if the product fails in a phase 3 trial, let's make sure that we put our best forward. We did the, you know, highest quality phase 3, and we know that it works or it doesn't work. But I do think we should be, to a certain extent, say, did this public-private partnership lead to results for the American people? And that's the ultimate criteria. The second part, though, is that, and again, I'll go back to my DARPA roots a little bit. I mean, you know, DARPA is all, you know, fail fast and have these just super ambitious programs. And I always tell the story that, and they say, oh, it's okay if you fail, except if it's your program, it's not okay if you fail. So you're sort of held accountable for that one. It's okay for the other PMs to fail. But the, so I saw a lot of programs that failed, and, you know, for various reasons. But I think, as much as I said the first criteria is success, I think we should celebrate when we are creating opportunity to learn, sometimes opportunity to fail. But that opportunity is taking a university, super smart PhDs or MDs, and giving that biotech a chance to do something very ambitious, so that even in failure, we're creating that American ingenuity. We're not afraid to fail. We're going to challenge. We're going to do something that no one else has done before. And so we also want to nurture that. And that's a different criteria. So, but I would go back to my comments that that's not done alone. When I say us, I want to make sure we're talking federal government, we're talking state government, we're talking philanthropy, we're talking venture capital and private equity. We're talking all of these different sources and ways that we can nurture that ecosystem. I do want to end, though, that the government provides leadership for all of that. And that's why I do feel like you need a federal government, I would say, organizer, catalyst, whatever the word, I think you brought up with BARDA Ventures. It's that crowding in capital. Let's leave it with leadership to hit that second bucket for American innovation.
Yeah, just to kind of feed off what Matt's saying, I think part of that success is also sustaining that success, right?
Sure.
And that's a really important piece that sometimes we miss. I mean, I think it happens all the time with some small biotechs, and even the ones that have been really successful in developing medical countermeasures, and then we don't necessarily follow up in the long term, right? Like part of Project BioShield, the objective, develop these countermeasures, but then later to be sustained through the SNS, or maybe that's through continued manufacturing and assisting through the commercial market and looking at those products that way. And, you know, the DoD has a product called War Stopper for those particular, you know, countermeasures that are developed, but then, you know, they should be handed off to continue to be sustained. So we have that capability for the warfighter, but sometimes that gap is missed. So I think part of that success is sustaining the capability.
Yeah, absolutely right. Yeah, I also wanted to pick up on a thread from Matt's comments. You know, I don't have a comprehensive set of criteria for success failure, but I think one thing that's instructive, to go back to the Operation Warp Speed as an example, they took a portfolio approach. And so there was a goal to have a vaccine produced for the American people in response to COVID. And I mean, there was a super high success rate, knocked it out of the park, right? I think just about every vaccine that was funded was successful. But if it had only been one or two, let's say, that still would have been a success, I think. We would have had vaccines for the American people. And I think that's the same approach that you see, again, in the venture capital world. I would argue for BARDA Ventures, DARPA, this idea we have for the Independence Investment Fund. Take a lot of shots on goal. You know, define your criteria for success, take a lot of shots on goal, and some of them will hit, and I think that constitutes success.
Fred.
Well, thank you. Thanks very much for your testimony. When we 10, 12, 15 years ago, we were seeing venture capital investing in new drugs and devices too, dropping on a declining rate, really to the tune of about 50%. We changed that. We altered the course. Thank goodness we had Peggy Hamberg at the FDA, and we had Francis Collins at the NIH, and we had Susan Brooks on the Energy and Commerce Committee, and we passed a bill that really helped lead the way. But now that we're seeing the NIH cuts go from, in essence, what was a path that would have reached $48 billion perhaps this next year to almost half that, 27 I think was the number. ARPA-H is probably on life support, which, everyone loves DARPA and all the things that they do. ARPA-H doesn't quite have that support, but again, it's on life support. Any early trends in terms of what's happening with venture capital, despite, just hasn't been a lot of months since we have seen this decline. But Joe, what's your sense in terms of where things are, if things in fact stay this way?
Yeah, so I think, as you said, the venture capital environment for biotech has been on a decline. I think it was a reference made in the last panel. Some of these cuts to NIH and more early stage basic science funding, we're going to see the downstream effects. It won't be tomorrow, but it might be 5, 10, 15 years down the line. Similar to the comments that Secretary Shalala made, this is sort of like the feedstock of the research, venture capital, startup, and then larger company ecosystem. It is really advancements in basic R&D that downstream give you something that you could build a startup company around, and it's mature enough that you could interest venture capitalists. They see the prospects for return, and then so many of the bigger biotech and pharma companies work with and sometimes acquire these startups to really boost their own innovation. So I think it is a problem. And I don't think that anything that the venture capital ecosystem does on its own can replace that early stage R&D.
Taylor, we're glad that we've seen you continue to have a great increase in terms of your productivity. You were a wonderful member in the Energy and Commerce staff. Mike Burgess reminds me that he taught you everything that you know. You saved them more than once. I know Burgess was a great player for us. In your new job, as we look at these supply chain shortages, particularly with the stockpile, what suggestions do you have that we need to follow up on, or that the Congress needs to do?
Sure. Thank you, and love Dr. Burgess, a wonderful man, and miss him dearly. I think certainly it's the Asper Industrial Base Expansion Supply Chain Office has continued to grow post Operation Warp Speed and has done a lot of investments in our manufacturing capabilities, large scale for those medical countermeasures, both within IBMSC and BARDA PCI, the BARDA Pharmaceutical Supply Chain Infrastructure Division, which did a lot of the investments early on, back starting in early 2000s to invest in that infrastructure. So I think it's continued investment to be able to do that. I think for the supply chain, it's also awareness of where those contracts are coming from the stockpile. It's sort of intermittent because of their annual appropriations, as you know, sir, and it's a lot of time on supplemental funding, and so it's not always consistent cadence on when those contracts are going to happen, when the modifications are going to happen. It's for these products that are not made in large scale, like commercial products in the medical countermeasure space. It's always sometimes hard to get space in the CDMOs to be able to do manufacturing and to know when that space is available. So having a surety and sort of consistency in contracting is really important.
Thank you. Yield back. Thanks.
Ken.
Okay, thank you. Just one question for you, Dr. Hamberg. You mentioned the state biotech agencies and the role they've played in the past, and you sort of mentioned that in passing. What has been that role? What are they? I don't know that you can generalize. What's been the role, and what do you see their role in the future?
Absolutely. Well, thank you for asking. No, it's one of my favorite topics. Where I saw it best is that it's sort of this idea of, again, I'm very supportive of the federal government providing leadership. I hope that's come across in my testimony. But I also think, the beauty of America is organic, community-based, people that know that community and can bring those communities together. And I'm like, that is still where the best innovation happens. And that's where we make our best progress. I think what I've found is there's permutations, all sorts of shapes and sizes wherever you go. But what I've seen is good examples, great examples of state governments. It doesn't take a lot of money, but the state governments sort of commit to that leadership convening role. They bring in their academic institutions. They create incubators, laboratory space and such so that these spin-off biotechs have a place to go and can do their early work. They recruit in finance, and then they link in with the larger pharmaceutical industry for internships and opportunities, and sort of they bring all these different groups together. And the point being is that there are places in this country where we've seen massive innovation, and they just do this naturally. And those places need to continue, and we love them. And I think the weather in Boston's terrible. I'm never moving there, but I love people from Boston. The point being is that these places are everywhere, and the exciting thing is that if we can nurture those, federal government support helps a little bit. It doesn't take a lot of money, but it takes the knowledge. I'll give you a specific example. In North Carolina, they had a great relationship with BARDA Ventures. And so the BARDA Ventures and the GHIC went to North Carolina and worked with what's called First Flight Ventures down there. And so it was the government, it was the federal government, the state government, venture capital, everybody coming together around those themes. And I'm sorry, but I could go on all day with examples. There's Heartland Bio in Indiana. We had a great trip to Puerto Rico where they do really best in class. Well, I did grow up in Ann Arbor, Michigan, but I felt like I shouldn't. I certainly wasn't going to bring up Columbus, Ohio, though. So that was a bridge too far. But I mean, we could go on Madison, Wisconsin, Austin, Texas. I mean, there are so many of these places, and it just takes a little nudge. And I've seen really great federal government programs that kind of nudge them a little bit, just to bring those together. But even with that little nudge, like the great innovation is going to come from there.
Peggy.
Thank you. Well, Matt, I've known you for a long time. I love your optimism, but I'm going to be the skunk at the garden party. I agree with everything that's been said, and I wholeheartedly endorse the concerns about the lack of continuing investment in some of the NIH research as a current sort of dark cloud on the horizon. But I think we're actually potentially facing a much more seriously changed world, and that we have to be clear-eyed about it. There is an ecosystem that has developed over now decades that supports biomedical research and innovation and our success in this country. And it involves economic policy, it involves regulatory policy and oversight, it involves investments in research, fundamental, clinical, directly translational, it involves government, academic, and private sector research. It involves pricing and payers, and it involves access. And all those things in an ideal world need to be aligned and pulling in the same direction to really deliver on the power of science and technology today. And every one of those components of our ecosystem now is being dislocated, if not actively under attack. And so I think, we really need to think about how do we respond to this changed world realistically and proactively so that we can continue to advance in the ways that we can because of the opportunities in science and technology and the expectations of the public in terms of what we're going to deliver. And I it's hard. I wish I could share, the sort of basic faith that we'll do it, and I think we will muddle through. But I just would like the reflections of you guys in the little bit of time that remains from your different perspectives and experiences on, how much this ecosystem is under siege and what can we do to try to piece it back together, creating new frameworks for economic incentives, the research investment requirements, strengthening regulatory certainty and predictability, and the issues around confidence that if you invest and make a product, it will actually get paid for and used?
Yeah, I'm going to have Taylor answer that question. I do want to. So I agree with you. Yeah, I'm just still in the mood of American resiliency and that American ingenuity, and it's still a land of opportunity. But I will pile on with you on a couple things. So I am out of government. I work for a small life sciences company, and we, like everybody else, feel in particular the situation in terms of with the Food and Drug Administration and the idea of clear regulatory guidance, and it's funny to be telling you that I feel it's really stupid, but because you know this so much better than I do, but I do want us to foot stomp this. And we would never say that you would want to compromise the safety, the efficacy, the integrity of the process. But what I've found in my limited experience now, but also through decades of working with companies, is they say, look, just tell us what we need to do. Set the standard and provide clear regulatory guidance. And that's done through clear communication, but it's also, as you know, it's done through the roll up your sleeves, reviewers engagement that the FDA does all the time, all over the place, and has sustained. And if you don't have a workforce to do that, how do you, once that falls apart, then that you introduce uncertainty. And I'm not a business person, but the first thing they say is the last thing we want is uncertainty. Uncertainty is risk, and clear regulatory guidance is the answer to that. I do want to also emphasize something that we haven't talked about yet, but I do, and I agree with all the things you brought up. The additional thing in my current experience is that I'm profoundly excited that America is still the land of opportunity, and we've had a lot of. I was interviewing all these MBA students to join our team and things like that, and it was surprising how many were from other countries. And I would ask every single one of like, why'd you come to the United States? And they were like, this is the best place in the world. This is the chance where I can take a risk, I can work at a biotech, and I can do something that I could not do in my home country or anywhere else. And I found that very inspiring. But the message is that we need to make sure that those people, that next generation of entrepreneurs who have the best ideas in the world, that they come here and they get to join our ecosystem and be part of it. And we should have the policies in place to encourage that rather than discourage it.
Yeah, I guess I just want to mention the important role, of course, Congress has to play here, especially in appropriations and ensuring that these agencies have the appropriate funding to still be able to do their jobs. We talked about earlier, for example, ASPR largely works on supplemental funding or annual appropriations, and for them to have that prospective view is critically important. So I think that time, and especially for us as we look at new leaders, as the Pandemic All Hazards Preparedness Act is, coming back up again, and as we try to get those pieces reauthorized, who are those leaders going to be? Congresswoman Brooks and, of course, Chairman Upton were all really important at the time. And so who are going to be the next leaders that are going to be there for this reauthorization cycle is really important.
Yeah, I'll just say, I think, Matt, you're clearly on Team Opportunity. Commissioner Hamberg, you might be on Team Danger. I
believe in the opportunity, but I'm worried that if we're not realistic, we won't be able to really achieve what there is out there.
No, I think that's fair, and I certainly don't have a comprehensive answer to all your concerns, but one thing I'll say is that I'm optimistic, and I've talked to others that are, that eventually the pendulum will swing back the other way, that there won't be cuts upon cuts upon cuts forever. And so one thing we're doing right now at the Commission, we have a project called The Future of Science, where we're looking at how can we improve the R&D enterprise, looking in particular at data and how we can do better there. Our goal is to have a set of ideas ready for when the pendulum swings back, and hopefully we can implement those and improve things when we start building back.
Thank you so much for your testimony and for your service. And yield back to the Secretary.
Since we're at the Partnership for Public Service, that added to all of this is without a dynamic public service, none of this would be achieved. And we owe a deep debt of thanks to those that continue to serve and have served before. During this meeting, we examined our National Biodefense requirements using a set of categories that we had in our national blueprint for biodefense. As all of you know, our commission has issued a series of recommendations, but those recommendations remain, while they remain relevant, but the landscape has changed, which all of us have noted, and it's shifted considerably. And so anticipating the future has been part of what we wanted to do in this hearing. And in closing, I want to emphasize how crucial it is for all of us to continue this discussion, not just for the future of biodefense, but for the future of our country. We, as a commission, continue our long-standing call and hope for both the administration and Congress to prioritize the possibility of a biological threat and provide those in the trenches with the support they need to protect the American people, but also the people of the world. So thank you very much. Thank you to the audience for your ability to sit through a very long day with all of us, and thank you to all the leaders that had an opportunity to give us their best ideas. Thanks, everyone.